All right, hi everyone. Thanks for coming to the Year 3B exam revision session. We'll be getting started now, and the first topic that we'll be going over today will be ophthalmology, which I'll be passing over to Meghna. And Meghna, just let me know if there's any issues with controlling the screen.
No worries. Thank you. Should we wait for more people to join, or did you want to move on?
I think we can just get started.
Started?
I think we can just get started because people will probably arrive and can join later as well.
Yep. No stress. Okay. All right. Okay. Hello, everyone. My name is Meghna. I am a final year student this year. I'll be running you through your opthal questions early this morning. It's a big day today, so I hope you're all stocked up with snacks and stuff. Let us get started. Oh.
Great. Maybe you can put it full screen as well if you want. Bottom left, bottom right, sorry.
Perfect. Okay. Good job. So let me see. Well done, Anne. So yes, basically this is allergic conjunctivitis. Conjunctivitis is one of your R1s. And sorry, I forgot to say this before, but basically this is as an add-on to my revision lecture. So I won't really be able to go through the content because there is very limited time. We're going to cover a lot of questions in 20 minutes. But conjunctivitis as a whole is one of your R1s. So allergic conjunctivitis is one type. We've got viral and bacterial and allergic. What points me more towards allergic is the itchy and irritated eyes. And she's got this past history of asthma, hay fever. There's a cobblestone pattern, which is a buzzword for like this allergic and bacterial conjunctivitis. So yeah, we treat it with topical antihistamines. All right, moving on. Okay, we might just move on because we've got 51 people. Am I able to skip? Maybe not. It's all right, we'll hang on. Oh, sorry. Oh my God. What's happened? Wait, let's pause this. Sorry, I'm just so. um, Okay, we'll go through question 3 and we can come back to question 2. All right, good job. So these lumps on your eyelid are quite similar, and it is important to distinguish between them. There are a lot of signs to help us like cross out a few of these options. So the fact that it is tender to touch means that we can already rule out a chalazion. So it's a hordeolum, and hordeolums exist on the inside of your eyelid or on the outside of your eyelid. Basically what it is a blocked up gland, and it gets infected. So yeah, we can cross out BCC because nothing in the history really points us towards that at the moment. But you would also want to consider it maybe in an older patient, or if even after doing your management, if it's not resolving. So management for chalazions and hordeolums is actually really simple and exactly the same. So what we get the patient to do is like wash their eyes with warm water, gently massage the area. And what you're hoping is that that blocked up duct can open up and it can clear. I might just go back to question 2, if that's okay. So yeah, a lot of you guys got blepharitis. So it is basically an inflammation of your eyelid margins. Again, sorry, I can't really go through them all in a whole lot of detail. But yeah, you get this blocked up. So your meibomian glands get become dysfunctional, and your meibomian glands secrete oils which cover like onto your eyelid, which is why this itchy dry eyes is also important in the history. Her eyes feel gritty with a foreign body sensation because of the dry eyes, but it is also important to consider a foreign body. The base of her eyelashes being crusted is basically the hallmark sign here. And past history of seborrheic dermatitis. So it is linked to seborrheic dermatitis and rosacea. The high blood pressure and cholesterol doesn't have anything to do with it. It's not conjunctivitis because it's been there for a week, and we've got this association with seborrheic dermatitis. And we've got dry eyes, so we haven't got like too much discharge. Endophthalmitis is a infection of the like inside of your eye, and it's quite severe. A corneal ulcer is a ulcer on your cornea, which is like the front of your eyeball itself. But here we've got irritated eyelid margins. Again, management is really similar. So we just want to manage the irritation and inflammation with warm compresses, cleaning regularly, and again, hoping to get the glands up and running. All right. Wonderful. If you guys have any questions at any point, please, like, I don't know how we can put hands up. Maybe you guys could shout out to Emil and we can get.
Yeah, we've got a mic, so
Very
if you want
cool.
to ask a question, you can put your hand up and I'll pass it over to you.
And online as well, if you guys have questions. Yeah. All right, let's continue. All right, good job. Okay, so good job, everyone who picked up that this ulcer is a dendritic ulcer. Keratitis basically presents with an acute onset of unilateral red eye and photophobia as well. And how we can, but just based off that, we can't narrow down that it's HSV keratitis, right? It could be bacterial, it could be fungal, it can really be anything. And when we're talking about keratitis, because there's a lot of itises and there's a lot of eye anatomy which we're not so familiar with, we're talking about the cornea here. So the cornea is, this is a corneal ulcer basically, but it's a specific type of corneal ulcer. And when we're looking at this second sentence here, so you look at get a slit lamp, you look at it with fluorescein drops. So these, you might have had this if you've been to an optometrist or something, but basically they put a little orange drop in the eyeball and then look at it with a slit lamp with a blue light, which is why it looks all blue. And if there is a ulcer or, you know, some sort of a scratch or something, that will light up with this green that you can see here. So it's dendritic because it has these sort of dendrite patterns. It's strongly associated with HSV. You won't see this with VZV, and you won't see this with bacterial either. So this is very buzzwordy, and we just treat it with acyclovir. The reason it's not allergic conjunctivitis is because we've got this picture, and retinal detachment is in the back of the eye as well. So we can't say that he's got a retinal detachment looking at the front of his eye. Okay. Okay, in the interest of time, I'll just move a bit quicker. All right, smashing it. So yes, uveitis. So this patient has acute bilateral red eyes and a dull aching pain. So dull aching pain is what points you more towards uveitis. Again, please have a look at the revision lecture. I can't really cover the anatomy in this time, but your uvea spreads, basically goes from your iris to the back of the eye in your choroid. So when we're talking about uveitis, it could be inflammation along any of those anatomical landmarks. When we talk about it in a year 3B context, we're talking about anterior uveitis. So it's mainly the iris and the ciliary body. What this patient has is irregularly shaped pupils, and that's because there's all these adhesions around your iris, which are sort of pulling the muscles in these irregular shapes and causing a deformity. Past history of psoriatic arthritis and IBD is important because it's associated with autoimmune conditions, and it can come up, it can flare up multiple times in a patient's lifetime. It's not a retinal detachment, again, because your retina is in the back of the eye, so we need to look inside to actually see it. It's not bacterial keratitis or conjunctivitis because we haven't got a bacterial cause really here. And the dull aching pain, your conjunctiva is like very sensitive, which is why if you get like an eyelash in there, it really hurts. But this dull aching pain points to something further back in your eye, if that sort of helps, in your uvea. And how we treat this is with topical steroids, and we dilate the pupil because that relaxes the ciliary muscle spasm that's associated with these adhesions. So dilating the pupil can help with reducing the inflammation and helping with the pain associated with uveitis as well. And uveitis can present unilaterally as well in your stems, so just keep an eye out for that don't use that as a differentiating factor.
Just for the people in person, sorry about the slides being a bit small. I've changed the settings so that if you join on your computer, it will show the question on the screen of your computer, which might be easier to see.
All right, might move on. Good job. Episcleritis. So this is a really benign condition. This is and what points us towards episcleritis, like what are some good signs here? So we're seeing that there's very mild discomfort, basically like it's not bothering the patient at all. There's no changes to VA, no discharge, no photophobia, no past trauma. So this second sentence is very reassuring, right? There's moderate redness in the white of his left eye. There's full range of movement, no double vision, all very reassuring. And we've got no past history either. So it's not a bacterial keratitis because there's no pain. Keratitis is very painful. It's not allergic conjunctivitis because it's not presenting itchy and inflamed. And it's not a cataract because a cataract is your lens getting opaque. So this is the whites of his eye being inflamed. It's basically like the topmost layer of your sclera is a bit irritated. It's very self-limiting disease, often idiopathic, happens in younger people, lasts for a few weeks, and you just sort of reassure the patient. You can give them some like Panadol, Nurofen to manage. All right, a few more seconds. Okay, let's keep going. Good job, guys. Trick question, haha, gotcha. So when we're talking about bacterial keratitis, what we're talking about again is an inflammation of your cornea, and it's has a bacterial pathogen at the cause of it. So what makes this bacterial keratitis? Let's first go into that. It's an acutely painful red eye, unilateral. There's reduced visual acuity, photophobia, no ocular trauma. The contact lenses is a huge buzzword or factor that should raise suspicion of bacterial keratitis, especially poor contact lens hygiene, which allows bugs to get in and grow. So a hypopion, just because these like words sometimes can use to confuse me. So hypopion is this like little buildup of white blood cells you can see in your anterior chamber here. So this, yeah, it's just like your discharge is like building up in that area. It's associated with like bacterial inflammation more often than not. Opaque cornea, so what we see here. Purulent discharge, yeah, pretty self-explanatory, and a corneal ulcer, like we're seeing here. So this is different to that dendritic ulcer that we saw. A corneal ulcer doesn't really have a shape like this. Okay, moving on. Okay, well done. Okay, let's go through cataract and glaucoma. So the reason this is a cataract, because again, these two words, like they don't really point you towards what it is. It doesn't say like lens opacification or whatever. So glaucoma, when we talk about glaucoma, that's raised pressure in your eye, okay? And your cataract is actually your lens becoming opaque. So as you can see here, this like you can see there's like this white hazy thing in the white in their pupil. So that's the lens that's becoming opaque. And if you imagine like looking through glasses, which are all foggy and becoming more and more opaque, what you would see is blurry vision, halos around lights at night, difficulty driving, no pain, right? So that crosses out viral conjunctivitis. It crosses out episcleritis. We have no pain. Okay, impacting his ability to function at home. So we can see this is like a chronic, slowly progressive disease. Red reflex, the lack of red reflex also points strongly towards a cataract. So when we do a red reflex test, what we're looking for is the retina to shine back at us. But if there's a foggy, opaque thing in the middle, the retina won't shine back at us. So you can't see the red reflex. Vision is worse in the right eye than the left. That's because a cataract in each eye develops in its own time. So while a patient who's had one cataract taken out will probably eventually develop a cataract in their other eye as well, it doesn't have to develop bilaterally at the same time. And what we can see here, there's this blurry vision with no visual field defect, right? So that also points us strongly towards a cataract, because in glaucoma there's and in other chronic and progressive ophthalmology conditions, there is a pattern of vision loss and a pattern of visual field defect. But in cataracts, it's just foggy. And we manage this with a cataract surgery. So this is a very benign procedure. It takes 15 minutes to do. We basically take out the lens and we put in a little plastic lens. And that is basically the definitive treatment, because it's plastic. It doesn't really like have an expiry date on it or anything. And the patient is good for life. Okay, well done. So this is acute closed angle glaucoma. It's very important to recognize this condition because this is a true ophthal emergency. So when we talk about glaucoma, just breaking down what acute closed angle glaucoma means, when we talk about glaucoma, it's just increased pressure. And there's, again, please recap the anatomy of the eye, because I can't really go into it very well, but there is an angle of your anterior and posterior chamber, and there's a drainage pathway. And that angle, when we talk about closed angle, what we're saying is that drainage pathway is basically closed up. And so if you imagine a drainage pathway closing up in a closed like eyeball, that pressure will build very quickly, and increasing pressure impacts your optic nerve, and it's like basically irreversible eye damage if we don't get to it quickly enough. And yeah, this presents very acutely. So when we have a patient who's got sudden unilateral eye pain, that is the angle has basically like closed up in only one eye. There's headache and nausea and vomiting because we've got increased pressure. Photophobia, halos around your light. Started 2 hours ago, so patients present very quickly because it's very, very painful. Hazy cornea, fixed mid-dilated pupils, a hard globe on palpation. These are all buzzwords for it. Intraocular pressure is if intraocular pressure is high, that's glaucoma. And then we need to figure out, is it acute or is it closed angle or open angle, right? I think management is less important for this condition, but just know that we give IV acetazolamide, which stops the production of aqueous humor. And timolol and pilocarpine also bring down your pressure. And in this patient, if she's had this happening before, we can consider this procedure called an iridotomy, which is the definitive treatment for closed angle glaucoma. Okay, good stuff. Let's move on. Well done. So let's go through chronic glaucoma, which is a very different picture. It's progressive peripheral vision loss. In this, it's not actually like the drainage pathway being closed off. It's sort of like an increased resistance in that drainage pathway. So it happens very slowly. Often people don't, so he's had this worsening vision for 3 weeks, but he's probably had glaucoma for like months before that. People don't realize because it's the peripheral vision going first. And eventually when it becomes pretty bad, that's when a patient might realize that they're having difficulty seeing. So that's what I mean when I talk about this pattern of vision loss, right? Optic disc cupping is a buzzword. It basically means that the ratio between your optic disc to your optic cup is changing, and that's from the increased pressure. There's no red eyes, the red reflex is present, so it's not a cataract. The headaches just has to do with the increasing pressure. It doesn't have to be there. And again, if you've got high intraocular pressure, that's glaucoma. Okay, moving on. Final question. Okay, maybe a few more seconds. All right. Well done. Oh my God, amazing. Everyone's right. That's sick. Okay, so retinal detachment, this is an R3 condition. So basically this is as much as you really need to know. It presents like a shadow coming down because your retina is detaching. And if you can imagine this happening in the back of your eye, you would sort of have this vision loss in that pattern. Eye vision is preserved in the other eye because the retina is still attached. We have flashes and floaters. So flashes happen because your retina basically has your cones, and like if they're being ripped away, like that is going to create some flashes. Floaters is like protein bits floating around in your eyes. No eye pain, no redness. So it's a painless vision loss, painless acute vision loss. We need to get this repaired very quickly because your retina isn't getting blood supply when it's detached like this, and it is neurological tissue, so can cause permanent vision loss. But yeah, acute painless vision loss, and it happens unilaterally. It's not closed angle glaucoma, uveitis, or hordeolum. But you guys already knew that. Everyone got that right. So well done. That's my final opthal question. So I will hand back remote control to you, Emil. If you guys have any questions, I don't know if anyone's put their hand up at the moment, feel free to shout a question out, or yeah, let me know if you have any questions.
Any questions from the audience? No, cool.
Amazing.
Darren, I'll pass it over to you. I think for this, we won't be doing a Kahoot. We won't be doing we won't do a Kahoot yet, not for this, but for the rest of them, I think we'll be doing a Kahoot. Here's the podium. Do you want to just go in? Just letting you know, this is the slide with, this is a PowerPoint with, oh, wait, 1 second. This is a PowerPoint with all of the questions on it. And that will be shared after the day today.
All right, so hello everyone. My name's Darren. I'm 4th year and I am at the, which hospital am I at now? I'm at Maroondah and for pediatrics, which is pretty fun. You guys should enjoy it if you're on it next year. I had a pink pen, but one kid ate it or licked all over it. So I had to give up that one and I bought a Winnie the Pooh pen for the last couple of weeks. Anyway, with neurology, so we'll be doing it in a couple parts. Basically, the questions are pretty short. We'll just do it in the middle and then we'll just go through each one. I think the lecture covers it okay. And then we will do some cases though to start with and at the end as well. And I think it will help with your Apex if you haven't had it either. For the people on Zoom, the case will be a bit hard, but I pasted a link on Google Docs. You can look at them there. But I will need volunteers for the cases. Arguably, if you volunteer, it's an easier job than if you don't volunteer. So I'll need 5 volunteers. Frank, thank you. Shang, come on down. I need 3 more. Sure. Thanks, Alyssa. 2 more. So these are they just pick one of the patients and then they'll ask you questions.
Okay. Patient one.
Yeah. Yeah, so you're pick one.
Light.
Maybe there's a girl one actually.
Just like
That's
Three.
Yeah.
One.
You wanna take 3?
Okay, cool.
All right. I'll split the rest of you into some groups. Let's say these first 2 rows here. So you guys together, you'll have to brainstorm 5 questions, and the presenting complaint for all of these patients is headache. So you guys brainstorm. You only get 5 questions, not a full history. You guys 5 questions for another patient, and then we'll go. You guys 5 questions. Sure, I'll give you a couple minutes, and I'll brief them on that, and then yeah, ask you questions.
Is that a national chess competition?
Chess, yeah. Which
So
who's who?
all I'm saying, 1, 2, 3.
Okay.
So we're saying that will happen.
Yeah, it's like you know it well, like the condition. Yeah, but as in everything else, you pretty much know.
Yes, headache. And
Yeah, you can make up other stuff.
do I have
if you want.
photophobia? No,
No.
just headache.
Yeah. Are you fine with? Yeah, that's chilling. And
Chill.
then migraines.
So
That's a
chill,
class.
that's
Well, they can ask just 5 questions.
Yeah. See if I
Okay.
can get the data.
honestly, no brainstorming time. They should be able to think about it on the spot. It's thought already.
I'll give you the other 2 patients as well. So one of you has a sub route. Yeah, but then this person with polycystic kidney disease. So the dad's on dialysis. Who wants to be that one? The second time.
We can do 1, 2, 3, and
4, and then there's one more. 5.
Sure, I can do the last
all
one.
right.
Okay, so 5 is it's not a new. Oh, it's not really neuro, but giant cell arthritis.
Oh, that one's a nice one.
Yeah. You can look at it.
I should read them.
Just turns in.
Actually, I forgot we had 5 patients. So, this row, 5 questions as well, please. And then we'll go to this row, 5 questions as well. Thanks. I think we'll get started. Last time.
Okay,
I think we should.
So who's first? Frank,
Me, yeah.
17-year-old.
Can you correct me if I say anything wrong?
Oh, sure. All right, you guys ready? You can change your questions as you go if you feel like their answer is something different. So Frank is a 17-year-old like guy who presents with headache.
So Frank, whereabouts are you feeling the headache? Can you show me? All over? Okay.
Frank, could you describe the pain?
Yeah, it feels like something pushing on my head.
Is this a new or a long-standing headache?
You have to do like HOPC for like history of presenting pain. If you want to ask other stuff within the 5 questions.
Do you feel feverish? No.
Have you noticed any changes in the sensation anywhere in your body?
All right, Frank. So what do you have?
I have a tension headache.
Yeah, good. So I feel like from that you should be able to tell tension headache. But then the questions you ask, other questions you would probably ask. I think it was good you tried to rule out some things like with fever and like the other questions. But you could ask for stresses. If you think tension headache, just ask if they have like social stresses, and he did. In this case, that was good. Thanks. All right, you guys next. What's your demographic? Okay, so Shang is a 30-year-old male with headache.
Hi Shay, where do you feel the pain? Where do you feel the pain?
One eye. One side of it. Yes. Around one eye.
Have you noticed any watering of the eye?
Yes. Yeah, Apex, you gotta rule out other stuff. So even if you think it's something pretty obvious stuff, start off with.
Have you ever had this before?
Do you have a fever?
Any changes to vision?
Yeah. So what do you think he has? You go.
Cluster headache.
Yeah, so pretty classic cluster headache. But like for assessments and in real life, just because they have a unilateral headache that's watery doesn't mean they have a cluster headache. But it's good you guys ask for other questions like fever, some migraine stuff as well. And yeah, 30-year-old male, in an exam question, like they probably, like that kind of be the demographic. It wouldn't be, yeah, that'd be the demographic. Okay, so Alyssa is a 23-year-old girl with headache. Where is the pain?
Did you have any symptoms before the headache came on?
Do you find any sensitivity to light?
Have you had any shining light in your field of view? Shining lights, like auras in your field of view?
Go on.
Do you have a fever?
Do you have this? Have you had this before? Is it recurring?
That was 5. Oh, you want me to ask you if you had chocolate, man?
Yeah, so Alyssa has a migraine. Yeah. Other questions you could ask, like don't, like you guys are all asking the history of presenting complaint. Like feel free to ask other stuff. That's why it's 5 questions, right? So if you feel like you are pretty fine with the diagnosis presenting complaint wise, like think of other risk factors or history. So migraine, like family history or past episodes was a good one. Okay, so now we're back to Frank again. Are you 21, Frank? Fits well then. So 21-year-old male with headache.
Where is the headache?
How long have you had the headache for?
Do you have any sensitivity to light?
Do you feel feverish?
Was there any recent trauma? What does the headache feel like? Can you describe it? That's 5 questions.
Pardon? He asked any like family history of any conditions. But if you're thinking like polycystic kidney disease in the exam, you can ask like, do you have history of any kidney issues or like anyone on dialysis? All right, so our last headache one. So Alyssa is a 65-year-old, so a bit different to the previous ones, and she has a headache.
Where is the headache? What does it feel like? Do you have any fever? Do you have any medical conditions? Have you had any vision changes?
This might be a personal question, but would you consider yourself overweight? Random, but sorry.
Like malignant hypertension, potentially?
What do you think she has?
Is it malignant hypertension?
Oh, that's a good guess. It wasn't what I thought of in this case. Yeah, but I think from what you guys asked, you probably hard to rule that out. So anyone else has any other questions then? So 65-year-old, sort of fleeting vision loss in one eye, we'll say, not both eyes, so probably not malignant. And then, yeah.
Yeah, it hurts the too a bit. Yeah, oh yeah, now you mention it. Oh, my shoulders would be really stiff. Yeah, man, when I wake up, I can't, it's so hard to walk out of bed.
Yeah, so what's the diagnosis? Yeah, temporal arteritis or giant arteritis. Not a neuro condition, I don't think, but it's a headache thing. So yeah, good to keep it in mind. Yeah, so as you guys can see, like some of the questions are very useful and then some of them like okay, but where is the headache is very important for headaches. And then comorbidities and the patient demographic will help you a lot with questions as well. All right, we'll do, I don't think we have enough time to do the questions and some more cases. The cases will be collapse and there'll be 3 of them, or we can do some like random exam questions.
Yeah, I agree.
All right, cases, sounds good. Are you guys happy to continue? Yeah, sure. So, collapse. Yeah. So, yeah, cases collapse. We'll go. Which groups didn't have a go? Do you guys want to come up with 5 questions, like you two and the 2 sitting behind you? Sure. And then you 3. Is that fine? Yeah. And then the 5 at the back. So collapse, 5 questions for collapse, and everyone else can have a think about what it might be. But yeah. Who wants it out? Sure. Oh, do you want to act it out?
Pass out.
No, but you're watching a scary movie. Yeah. You should like jump up and die. Not die.
So Frank's doing Ah, thanks.
Good deal.
Yeah. One of you the cardi.
Yes.
What's it? Epilepsy.
Yeah, that's fine.
I got the easy one. It's before for me.
I hate them. Like, I hate them so.
Yeah. No, it hasn't. I try to avoid clowns.
ASMR.
All right. So
There you go.
all right. So Frank is a 17-year-old who was recently, actually no, I wouldn't give too much of the history. Yeah. So collapse. 17-year-old.
Did you lose consciousness?
Did you feel any symptoms before you collapsed?
Did you have any palpitations?
Ah.
Did you witness anything before you like collapsed?
Maybe like postural hypertension. Did you stand up very suddenly before you fell? Vasovagal.
Palpitations. Were you thinking of anything with palpitations? Pun. But like what cardiac? He's a 17, I forgot how old, 17? Yeah, 17-year-old. Anyone have any cardiac causes for Frank? Yeah, Hockham, yeah, pretty known for like young person and then suddenly collapse. Or like something congenital as well. But yeah, it was a good question. Okay, so next we have Shang, who is yeah, so this happens to him. He's how old? 60 years old. Yeah, that's the key part. Yeah, so urgent history on him. 60-year-old male with collapse.
Did you lose consciousness? Oh my God. He did lose consciousness. You can ask.
Sure, that's a heart problem, right? It looked like those are the wheeze because he was getting short of breath. Let's ask him. Or chest pain. Because he was just clutching his heart. Chest pain or like sort of medical problems that he has. Yeah, sure.
Do you have any medical conditions?
Yes, I have high blood pressure and diabetes.
Okay, thank you.
Do you have any chest pain, shortness of breath right now, or when you collapsed?
Yes, I had shortness of breath when I collapsed, and I'm also just a little bit short of breath.
Did you smoke a lot, or do you smoke?
Wait, so when you take a deep breath in, does it hurt more?
Yeah, that was fun.
What do you guys think is going on?
COPD, CCF, something like COPD, CCF, kind of. Right?
He might have that, but do you think that could cause sudden collapse, a congestive heart failure?
Necessarily, that could be the background.
So you think he like decompensated?
Yeah.
Suddenly? Sure. Yeah, and then COPD, why would he suddenly collapse?
I mean, just based on the smoking history and like the wheeze that he had, then wheeze. I don't know if that was like supposed to be, but
ACS as well.
yeah, it could be just like it could be like sort of like
Yeah, sure. So these guys were thinking COPD, decompensated heart failure, like valvular issues. So let me think. If I said like he went out like a light, what condition or what would that be more likely to be? Yeah, arrhythmia or like aortic stenosis. So in this case, I built him to have aortic stenosis, but other history parts where he had like shortness of breath and some chest pain leading up to the event. I think COPD, you shouldn't really get like chest pain and then a kind of sudden collapse. All right, Alyssa is 15-year-old girl who collapsed.
Do you remember what happened before you fell?
Did you lose consciousness?
Was there anyone around you who witnessed like what might have happened when you were unconscious? Like, did you have a seizure or anything like that?
Wait, what was that last part?
Sure. Yeah. Okay. Yeah. Go with that.
Okay.
So dad found it on the ground.
After you came, like after the fall, like were you like really, really tired after? Like how long did it take you to recover?
Have you had seizures in the past?
Yeah. You guys have more you want to ask? Any like, so what do you guys think is going on? Seizure. Any other questions you'd ask for seizure? Oh, yeah.
Did you lose control of your bladder?
Any other seizure? Oh. Yeah, that's a good question. So family history of epilepsy. Doesn't have family history of epilepsy. Anything else? The actual treatment itself. Did you have like twice your arm? Did you have problems with the mouth? Did you have anything? Yeah, so she had epilepsy. So sometimes like in the apex, I guess this is my apex, but you might know the diagnosis straight out, but ask more questions that are like zone in more on the diagnosis and then screen for other stuff as well. And then sometimes you might not know what the diagnosis is. So I had one that was headache. I forgot the demographic, but headache worse in the morning and then some sort of weakness as well on one side. What do you guys think that is? Yeah, it was malignancy. I didn't know the thing about like worse in the morning, but yeah, so that was a tumor. I didn't really know. I said migraine and I passed, but I didn't, I didn't know the diagnosis. I just screened for stuff. Right, yeah, thanks to Frank, Shang, and Alyssa. Please give them a hand. Yeah, and that's it with my quiz case part. If you have questions, just send me a message. Same.
Good to see you.
Good to see you. I'm not sure which one's working.
So,
Just go for it.
Yeah, do you want to be the one controlling that?
From here?
Yeah, you can
Or
speak
from there?
up, yeah.
Okay, yeah. Sure.
It's cool, actually.
Yeah, that's all good. Alrighty. Good morning, everyone. I'm Hussein. I'm one of the fourth years, and I'll be taking you through REST questions today. So if you guys have any questions, let me know. I'll do my best to answer them. So there's about 20 questions. They're a mix of like key concept questions plus some cases. So hopefully we'll smash right through them. Any people? Oh, yeah, yeah. All right, I think we'll get started. Just to let you guys know, the questions are in no particular order in terms of difficulty, so they're a bit random. All right, I'll start now. Sorry, guys. Oh. We'll go back to the first one. Sorry about the size. Yeah, well done, guys. So it's pretty easy one. So yeah, you get with COPD, ratio is less than 70%, and then you don't get reversibility on bronchodilator. Okay. Alrighty. Well done, guys. So yes, the answer is primary spontaneous pneumothorax. Does anyone have any questions from that? No. All right, we'll move on to the next one. Next. So this is a bit of a buzzwordy one. Excellent. Yeah, so there seems to be 17 people who chose TB. So just remember, your caseating granulomas is your tuberculosis, and then your non-caseating is your inflammatory conditions like sarcoidosis. So it's a bit of a throwback to PATH. And Jaffa number 1. Well done. Yeah, it's a bit of a tough one. So I'll go through it. So we know it's it's going to be on the right side because we have tracheal deviation to the left. So there's a buildup of pressure on the right. Now, how do we differentiate between a pneumothorax and hemothorax? In pneumothorax, what do we have? Air, right? So if there's a buildup of air, what type of sounds are you going to get on percussion? Are you going to get dull or hyperresonant sounds? You're going to get hyperresonant sounds. That's correct. So in the question stem, it said we have dull percussion sounds. And because it's dull, we're going to have some sort of solid or liquid on the right side. Therefore, it's going to be hemothorax. So we're going to have some blood on the right side. Therefore, we've got the dull percussion note. So it's a bit of a trick question. So well done to the guys who got it. Any questions from that? Oh, all right, we'll move on. Sorry about the fun. That'd be good. Can we do that? Or it's a bit tricky to start. Yeah, well done. So yeah, it is silicosis. And can anyone tell me why it wouldn't be asbestosis? Anyone? Yes, that's correct. Yeah. So with asbestosis, it also presents with mesothelioma, which is that pleural lining cancer. And it's more lower lobe predominant. However, in the question, it's more upper lobe predominant, like silicosis. And it's not sarcoidosis, as it's not associated with occupational exposures. And you usually get extra pulmonary manifestations in sarcoidosis. And then idiopathic pulmonary fibrosis is more of a diagnosis of exclusion. And then hypersensitivity pneumonitis, that's also not occupational. So it's a very occupational exposure based question. So well done, guys. Yeah. Yeah, I think we could do that. Yeah. Yeah, we'll just. I've been doing my head. I just haven't seen it. You've done, yeah. All right, guys, well done. So there is a bit of a mixed bag. So here we've got a case of someone who's got an open pneumothorax. So clearly they've been stabbed. There's the lung is exposed to the atmospheric pressure. Okay, so we don't need to needle decompress, because needle decompression, that's only when you want to relieve air that's trapped in the lung, and you want to relieve that air out towards the atmospheric pressure. Okay. So that leaves us with either, and the same thing in the intercostal chest drain. Because it's open, we don't need either of them. What we want is a three-way occlusive wound dressing. And I explained this in my lecture, how it kind of works. If you think about it, I don't know if you guys, when you were kids, you used to get like the Glad wrap, and you put it on your mouth, and you kind of breathe in and breathe out. And when you breathe out, the Glad wrap kind of just expands because of the air, so all the air gets released. And so when you breathe in, the Glad wrap goes, like a little bit of it goes in your mouth because of that vacuum that you've created, right? So it's the same thing with the dressing. When you breathe in, that dressing is going to close, so no air is going to come in through that the one side of the wound dressing that's open. And then when you breathe out, that air is going to exit from that wrapping. Does that kind of make sense? Yeah? Is anyone confused about that? No. All right. And slowly, the more that patient breathes, the more of that air that's going to go out. So air is going to leave the lung and no air will come back in because of creating that vacuum when that patient breathes in. Does that make sense? Okay. I think we might just take a pause because I want to try to get the questions on the right screen and then the Kahoot on the left screen, just so it's a bit bigger for you, all right? So we'll do a little pause. Can you drag it? Like if you go here? No, I won't work. Yeah, extend. A little bit drag it. Nice. Yeah, there we go. Easy. Alrighty, let's see where the leaderboard is at right now. Jeff is still on top. Well done. Okay. Yeah. All right. Next question. I'll try to press it at the same time. There we go. That's all right. Yeah, it's a bit of a mixed bag as well. But a lot of you got the correct answer. So because he's already got established interstitial lung disease, so he's already had that history, and it's just an exacerbation or worsening of his lung disease. And unfortunately, with interstitial lung disease or pulmonary fibrosis, because of the irreversible damage, there's not a lot of current meds that will help with that. So the best we can do is provide pulmonary rehab for them. Okay. Oh shit. All right, you guys know the answer. Well done, guys. Can anyone tell me? So we know that CTPA for a PE. Oh, well, he's got a PE here. Yes. Can anyone tell me why, despite CTPA being gold standard, is not appropriate in this case? That's exactly right. Yeah, right. So he's got poor renal function, and obviously with the dye that's used in the CT scan, we can't use that. So that's why we opt for the perfusion scan. Does that make sense? Alrighty. We got a shift in the leaderboard. This is a buzzwordy question as well. Yep, excellent. So almost everyone got it correct. So yes, bronchiectasis is one of the causes of clubbing, and it'll be good. Hopefully, you guys know the different causes of clubbing. Does COPD cause clubbing? Excellent, well done. Well done, guys. What does he have? Yeah. So again, buzzword, hip joint replacement surgery. All right. And one of the main signs that you get is the pleural rub. Okay. Jaffa still in the lead. Someone's already on the ball. Well done, everyone. So yeah, this is just trying to assess how well you guys know your asthma management plans. So if you guys just ingrain, I'm sure you guys have seen the diagram of the asthma management plan. So he's already on salbutamol 3 to 4 times per day. So that is a lot, and he's getting frequent episodes. So what we want to do is we want to go up in the management. So step 2, which is going to be prescribing him a ICS. Okay. Now, can anyone tell me what's one thing that we have to consider that happens in the mouth when a patient gets ICS? That's right. Yep. Well done, guys. Yeah. So I heard a couple of people say it there. Yep. So oral thrush. So we, in our counseling next year, when you guys do the OSCEs, I don't know if you guys have OSCEs anymore next year, but if you guys do, yeah, part of your counseling in an asthma plan is to tell them that when they're taking an ICS or preventer medication, it's to rinse out their mouth after taking the medication, as well as the spacer as well. Yep. Well done, guys. So again, pretty buzzwordy. Pain on inspiration. She's been bed bound, shortness of breath, low OSATs, and ECG. So yeah, ECG, sinus tachy. That's pretty in terms of Monash exams, pretty pathognomonic for PEs. And one thing that you guys get taught as well is your classic S1, T3, Q3. But one thing I'd advise is that in PEs, only a small percentage of patients actually get those signs. So it's not a lot of patients that get those classical signs. So if you want to rely on trying to get your marks in the exam, in terms of a PE, if they provide an ECG, sinus tachy is a pretty reliable sign of a PE. Any questions with that? All right, we'll move on. So we'll get some easy ones now. Hopefully they're easy. Yes. So, yeah. So this is a buzzwordy one. So pulmonary fibrosis, honeycombing. So you'll see that on imaging. Yep, well done. So a couple people selected Haemophilus influenza. So that's more like the patient group or the population group is more with children. But yeah, cystic fibrosis, that's the main one, Pseudomonas. Hold on, guys. On top of your physiology. Yeah, so type 1 rest failure. So that occurs when like the respiratory system, it can't adequately provide oxygen to the body, and that leads to the hypoxemia. All right. But type 2 rest failure, that occurs when the rest system cannot sufficiently remove carbon dioxide from the body, leading to hypercapnia. And one way to remember this is that type 1 will only affect oxygen, and then type 2 will affect both oxygen and CO2. Okay. Does that make sense? Alrighty. It's getting tight at the top. Well done, guys. So again, on top of the physiology. Yeah, so how I remember it is your transudative is kind of like inside or coming from like the vessels, and then exudative that comes from like the lung tissue itself. That's just how I remember it. Does anyone, for bonus, what's the criteria that we use to differentiate? Well done. Yep, well done. So almost everyone got it. Pretty self-explanatory. A couple of people chose tracheal deviation towards the affected side. It's going to be towards the opposite side because you've got that buildup of pressure. Alrighty. Almost done. Well done. So signet ring signs. Yes, it's kind of a buzzword thing to pop up on exams, but it's also important to understand why we have that sign. So with bronchiectasis, because we have that constant mucus buildup in the bronchus or the bronchioles, air can't flow through, right? So it has to constantly dilate, and because it constantly dilates, as the more mucus you build up, it's going to start coming close to the pulmonary artery or the branches of the pulmonary artery associated with that individual bronchus. And so if you can imagine that, because it starts to impinge on that pulmonary artery, you get that signet ring cell or signet ring sign. Does that make sense? Yeah. All right. I wish I could give credit to myself, but I just got a couple of resources, stole a little bit from here and there. Well, I did. Thank you. Yeah, well done. That's really, really good. So yeah, on the X-ray, you can see that there's the loss of it's like it's common of a pneumothorax because you have the loss of the linings or the markings. So then yeah, you're going to get that hyperresonance on percussion on that right side. Does that make sense? Yeah, all good. Last question. We're going to end on a case question, I think. Well done. So yeah, it is a bit of a hard question, but if we break it down, it should be simple enough. So we can see that 1-day history of shortness of breath, sharp, worse with inspiration, flew home to Adelaide. So we know straight away it's going to be a PE. And then it also, the stem tells you that it's in addition to sinus tachy. So we know it's going to be a PE because sinus tachy is related to PE. Which one of the following ECG changes is most likely present? So we can kind of go through a process of elimination, right? So ST segment, no, it's not having a heart attack. New onset left bundle branch block, that's more associated with MI. Prolonged QT interval, that's more associated with patients taking certain medications like SSRIs. And then what condition will you get ST segment elevation or the precordial leads? Yeah, that's right. So it's going to be pericarditis. So then that leaves just the T-wave inversion in the right precordial leads. So let's see the podium. Jaffa #1. Well done. All right, guys. Thank you very much. Good luck for your exams. You guys clearly know your stuff. If you have any questions, let me know. You can find me on Facebook. It's all good. Yes, right. I'll try to do my best to answer. Yes. Oh. Spoiler alert. Yeah. All right, let me just put down the volume. So your question was saying hyperresonance, any pneumothorax, and then JVP. Look, it could potentially be. I am not exactly sure. I'll have to have a think about it. But yeah, it could be. Sorry, I couldn't answer it properly. But yeah, well done, guys. If you have any questions, let me know. Message me. And good luck with your exams. Thank you. Sorry, I can't stay.
Yeah, that's all good.
Thank you very
Thank
much.
you.
I appreciate it.
Great work. I like your still recorded lecture.
Oh, did you? Thank you. I appreciate it. All good. Hopefully it's
Yeah. I'm sure. Thanks.
Thank you very much. Take care, guys.
See you, mate.
Thanks for sending this out.
Basically just this kind of lags, so you can get
Thanks. Either one.
Okay. Okay, everyone, let's start. I'm going to run through GI and hepatobiliary. Okay, I'm going to start. So just you can sign in later. What? Okay. Hi, everyone. I'm Carolyn. I'll be running through your GI hepatobiliary lecture. Hope you enjoy. Great. So this is a 65-year-old man. He's more likely going to have adhesions. And then he's got a distended abdomen, tympanic with high-pitched sounds. This is obstruction from adhesions. Adhesions come from surgeries, yeah. Yeah. Don't know if they can have them without surgeries. I don't think so. But good question. From Crohn's you can, yeah. So that's probably an exception. Good question, Maria. Okay. Great. So most people got it. This is acute mesenteric ischemia from arterial embolism. So this woman, she's 70 with AF and sudden abdo pain. This is acute, not chronic. This person has uncomplicated diverticulitis. So the management for this person is they don't need to stay in the hospital. They just need augmentin. And then for complicated diverticulitis, it's GAM, gentamicin, amoxicillin, and metronidazole. They don't need surgery because it's only uncomplicated, and they don't need to be in the hospital because they don't have infection, they don't have systemic signs of infection, or they can't eat. And then definitely not D because that's not serious enough for diverticulitis. So it looks like most people did Mallory Wise. Let's have a look. Is that right? Yeah. So he has peptic ulcer disease, and this is most likely because of his NSAID use. Risk factors include H. pylori and NSAIDs, and then other less clear risk factors include smoking, alcohol, and psychological stress. It could have been an esophageal rupture given how much blood there was, but this happens yeah, but this is from a sudden onset of severe retrosternal chest pain. Great. So this man had Barrett's esophagus and then needed to be resurveyed, and he came back for a repeat biopsy and had adenocarcinoma. And so what we need to do is take out the cancer. Definitely not esophagectomy. We're not going to take out the esophagus. And then the others are, this one, for example, neoadjuvant chemotherapy isn't, I think it's not enough. It's too much because this is just a 1 centimeter lesion. So for this answer, it's also endoscopic mucosal resection. And in cases without high-grade dysplasia, endoscopic radiofrequency ablation is quite appropriate for a flat Barrett segment. However, when there is any nodularity, as is the case here, endoscopic mucosal resection is the preferred treatment. We don't need, it's B is not correct because it's not the case of esophagitis, so we don't need to change his PPI. And a few people did repeat endoscopy in 3 months. That's not the case anymore because of the high risk of progression from high-grade dysplasia to esophageal adenocarcinoma, and repeat endoscopy is not appropriate because you have to actively manage this one. This question was very hard, and you're not expected to know it like this. I just put this in so that we can talk about the management of IBD. So for Crohn's, the learning points here are the factors in Crohn's that predict severe course of disease are young age, initial extensive bowel involvement, deep ulcerations, ileocolonic involvement, and other perianal severe rectal disease. So according to the therapeutic guidelines, induction therapy is PRED, and induction therapy for severe Crohn's is hydrocortisone. And for patients with severe Crohn's who can't deal with this, they will get things like infliximab, TNF inhibitors. For maintenance therapy, it's azathioprine and methotrexate. And for people with perianal fistulas, it's metronidazole and ciprofloxacin. Okay, so the thing that is indicative of worse prognosis in Crohn's disease is young age. But other things also include tobacco use, low socioeconomic status, ileocolonic disease, rectal involvement, and glucocorticoid requiring disease. Great. So most people identified that this is portal hypertension. This person has hematemesis, spider nevi, and pitting edema with shifting dullness. That's correct. Remember also that transudate is associated with things like congestive heart failure and hyperalbuminemia, and hyperalbuminemia and exudate is associated with inflammation or malignancy. Someone also had a question about this before, asking about IV infliximab. I don't think you have to know about whether or not infliximab is IV or oral, but ETG doesn't say from here. Yeah. Okay, next question. This question is asking about what's the most effective option, and that's bariatric surgery. And for those who don't remember what that is, it's this surgery here where we remove a part of the stomach, and so people feel less hungry. This question was really hard. So the two options would have been Mallory Highline or fibrosis, but fibrosis is not necessarily a diagnostic feature of alcohol-related liver disease and can also be associated with other types of cirrhosis. But for Mallory Highline and macrovecular steatosis, that's associated with alcohol liver disease. Okay, so most people did tips, which could have been an option. Another one could have been like they all could have been options as well. But the reason why we need to do a balloon tamponade here is because his blood pressure is very low and they can't identify where the varices is. So it's not sclerotherapy if they don't know where it is. And while tips is an option and for esophageal varices, it takes a lot longer than this, which is an immediate solution. And here's a picture of what the TIPS procedure does. So with this shunt here, it is reducing the backflow of blood towards here to reduce the variceal bleed. But as you can imagine, this is going to take a lot longer than a balloon tamponade. The ultrasound is a little bit mean, but you can still answer the question with the stem. Okay, great. So not most people, sorry. Some people did CT chest and abdomen, and that's right because these are liver mets. The reason why we know they're liver mets is he's had a history of anterior resection for carcinoma of the sigmoid. So he's had colorectal cancer in the past, and that's moved to his liver. Some other options, PET scan doesn't tell you enough. It only tells you distant mets. And hiated serology is not appropriate because that's for helminthic infections. Amazing. So acute pancreatitis is managed symptomatically, and one of the parts of acute pancreatitis management is what do we feed them? So because after 2 days, after his IV hydration, and since he's in no pain anymore, or he doesn't need pain control, we can just give him a low-fat diet while we give his pancreas a little bit of a break. However, we don't need to give him a significant break where he uses parenteral nutrition because he can still use his bowels. For this question, you also need the next slide, so I'll go back and forth. Sorry. Oh, people on Zoom. I'll just tell people on Zoom what's happening. So hepatitis B surface antigen is positive, hepatitis B surface antibody negative, hepatitis B anti-core antibody positive, and hep B core IgM antibody negative. And on liver function tests, AST is elevated, ALP is very elevated, ALT is elevated, GGT is elevated. Okay, so not many people got that right, but that's okay. Let's talk about it together. So hepatitis B core IgM antibody is negative. Does that mean they do or they don't have the infection? So the man in this picture, he has ascites and edema, and that fluid in his peritoneum has become infected, and he had spontaneous bacterial peritonitis. He has had hepatitis B in the past because his anticore antibody is positive and his surface antigen is positive. But the main point here is he's got the fever and the abdo pain in someone with a chronic liver disease, which is SBP. And what we need to do now is a diagnostic tap and then give him antibiotics. Okay, now we just got some pictures, so less reading. Okay, so some people did sigmoid volvulus and others did cecal volvulus. What is the thing that we use to diagnose sigmoid volvulus on an X-ray? Coffee bean, as someone astutely observed, is right here.
I think next will be this one.
Okay, okay. Okay, so this question is about sigmoid or any obstruction management. The first line, their management, is we need to give them an NGT, take out what's inside their stomach, what's inside their small intestine, just inside the stomach, so that we can give them we can relax their stomach. And then we also need to give them IV fluids. Then we can give them antibiotics if they need. They're both small bowel obstructions. Because if it's a large bowel obstruction, it's going to look a lot bigger than that. This is all small bowel. The large bowel is along here. Did anyone have any questions about this one? Sorry.
I'll just try and change the Zoom sharing. 1 second. Oh, this one. Yeah, we'll just finish.
Yeah. Okay, Mill's going to change screen sharing for the next presentation. Next question. Great. So this question was very buzzwordy. We have bird beak appearance, dysphagia, odonophagia, and regurgitation, which are all associated with achalasia. Final question. Okay, so this is a 25-year-old university student who's come with high-grade fever, headaches, and diarrhea. And he recently traveled to a region with poor sanitation and hygiene. This is Salmonella typhi. He's got bowel changes, splenomegaly, rose spots, and relative bradycardia are also features of Salmonella typhi. Anyway, well done, everybody. You all did amazing. Good luck for your exams.
Look at you, Mr. Muse. All right. Hello, everyone. My name is Rakeith. I'm going to be doing the heme Kahoot. Well, these questions will mostly be buzzwordy, I think, based on clinical scenarios. Give everyone a bit. Oh, I need to talk like this. Okay, great. Hi, Zoom. Everyone. Give everyone 1 more minute and then we'll make a start. Hopefully shouldn't take too long. Should I just start? Yeah. All right. Let's get into it. Hematology. Should be fine. Yeah, okay. Okay. I can't be bothered reading out these questions. Hearing a lot of groans in person right now. This is one of those questions where you just gotta make sure you read the whole thing. Yep. Yeah, nice. So good work to everyone that put in VQ scan here. Clinical scenario is very clearly a DVT that's predisposed them to a PE. That should be pretty clear from the history itself. I'm sure that the majority of you will probably know that the typical gold standard for DVT is a CTPA. However, big however in this case, is the fact that she's currently pregnant. How would you feel if you were a baby and then you got blasted with 2 years worth of radiation? I don't think I would have liked it. So do a VQ scan, all right? As for the other options, I think there were a few people that put D-dimer. D-dimer is a bit controversial at the moment. We typically kind of only reserve it for if you're ruling it out. There's this scoring system you can use called the Wells score to determine whether P is your most likely or least likely diagnosis. And then based on that, it's like you do a CTPA to confirm it, you do a D-dimer if you're trying to rule it out. That being said, there's some controversy around that because if it comes back positive, you're kind of like, I don't know what to do. As for the Doppler ultrasound, that will be good in the long term, just to kind of confirm that, okay, the DVT was from this location and it can help guide some long-term management. But go back to everyone that picked up that you need to do a VQ scan in this case. That's just the same thing. Well, this is just the same case, but they're not pregnant, because if they were pregnant, that would actually change the medications, and I don't know that well enough.
Very good. Majority of you picked up that this is provoked DVT for a 3-month course. Anyone? Actually, no. Crowd interactions, bad. So provoked versus unprovoked. Provoked just means that there's some cause that you can pin it down to. So in this case, if I go back a couple of slides, yeah. So the fact that they're a smoker and they've recently returned from the UK, so long flight, that's a major risk factor. That's an indication that it's been provoked. Whoa, that goes backwards. Does anyone? Okay, no, I'll just explain it myself. So in terms of why we do 3 months of anticoagulation for provoked versus unprovoked, where we do 6 months, the reason why, or the rationale behind it, is the fact that because provoked has a very clear kind of reason as to why it's happened, it's not random. And so because there's a cause, you don't need to worry about it too much. Whereas when it's unprovoked, you're a bit more worried because you don't actually know why they got a clot in the end. So you want to cover them for a bit longer, just to make sure that they're okay. Hopefully that kind of makes sense. The medication of choice is a DOAC. They're all DOACs, so that wasn't really a factor in this case. Yeah, cool. Let's keep going along. Yeah, it's the same thing. Clinical history in this context is kind of relevant, but you could just have the blood test as well and figure it out that way as well. Very good. So, in terms of, you can basically go off the blood test alone, but we'll just flick through to that one. So, increased clotting risk. They've had 2 DVTs, so you're worried about something that's going to increase the chance of that. And then looking at the blood test itself, I'll go back to it. Hemoglobin is normal, MCV is fine, white cells are normal, platelets elevated, right? So we've got an overproduction of platelets, and then also JAK2 positive. These are all kind of signs that are pointing towards this being essential thrombocythemia. And then, yeah, in terms of what the other things are, polycythemia is overproduction of red blood cells. PMF is overproduction of megakaryocytes, so the kind of progenitors of all of the myeloid cells. And then myelodysplasia is just abnormal growth of that stuff. If you look at the film itself, all of these like little dots everywhere, they're all the platelets. So that's just showing that there's more platelets than normal. Great. Ooh, bit of 50-50. So congratulations on seeing that the question has the word follicle in it, I guess. So in terms of what the other things are, Burkitt lymphoma, you're going to be seeing that it's quite aggressive. Buzzwords might be that it's seen in African children and that you get a starry sky appearance, while Hodgkin lymphoma is going to be Reed-Sternberg cells. In terms of how to differentiate follicular lymphoma from hyperplasia, the key word here is the word polyclonality. Let me flick through to that, I guess. So lymphoma is a malignancy of like one cell. So that one cell is going to keep growing over and over, and therefore it's going to be monoclonal. Hyperplasia is just the growth overall. So multiple cells are going to be growing. So you're going to have polyclonality. Hopefully that makes sense. Cool. This one's kind of mean if you don't know it. Nice, nice. I don't think I knew that last year. So G6PD, X-linked recessive, oxidative hemolysis, buzzwords are like, fava beans or whatever. Sickle cell anemia is a point mutation, you get sickle cells. And then alpha and beta thalassemia, there's 4 genes for alpha thalassemia. If they're all affected, you get hydrops fetalis, which is what is being referred to here. In beta thalassemia, if it's major, which means both genes are affected, they get like this hair on end X-ray and it presents kind of 6 months after they're born. So in this case, because it's talking about fetal death in utero, it's probably hydrops fetalis alpha thal. Great. Rough. So good work for those of you that were able to whittle it down to being one of the IHRs. For those that didn't, the way that we can look at it is on the blood test itself. So anemic, normocytic, and then look at the Coombs test. When it's positive, that means it's autoimmune related. The clinical presentation here with the sore throat and white exudate is pointing to an EBV infection, so glandular fever. That's also what the monospot is confirming. And then on the blood film itself, you see these like blobs. That's kind of not normal for a blood film. That's agglutination. So both of those are associated with cold, not warm. Warm is associated more with, CLL. The reason why it's called cold and warm, I think it's because like they happen at different temperatures, literally. Like cold is when it's less than 37 degrees, they get this. And warm is when it's greater than 37. I don't really get it, to be honest. But point is, cold is associated with EBV and you get agglutination, whereas warm with CLL? Yeah, rough question. Ooh, bit of 50-50 again. So, in terms of how to differentiate ITP and HSP, they present very, very similarly. The keyword here is the fact that it's most prominent over her buttocks and legs. That's very typical of HSP, whereas ITP just affects everything. And then some of the other things here that point towards it being HSP versus ITP. ITP is like the be sick, they'll have the rash, and it's literally just the rash. That's it. HSP has a little bit more going on. So you get like renal involvement, you get edema. You also get changes to the joints as well, which I found out like a week ago. So yeah, there's a little bit more going on in HSP. It's associated with your IgA vasculitis. And then TTP and DIC are way more severe. TTP is associated with this deficiency, which affects the von Willebrand. And then DIC is like systemic disease that means that you're constantly clotting. But yeah, that's how to differentiate them very briefly. Very good. So yeah, the fact that there's a BCR ABL gene is probably a buzzword that a lot of you know. If you look at the blood test itself, that actually like will help you figure it out. So there's a lot more of the purple cells, and if you look more closely at them, they've got like multi-segmented nuclei, which kind of points you that they're probably myeloid cells, not lymphoblasts. And then you have to pick between A and C, and kind of the presentation where it's like hepatosplenomegaly versus something that's a bit more like acute, which is maybe what you would expect with AML. It's a bit more severe and aggressive. Here are some of the buzzwords that you probably know already. But yeah, BCR, ABL, Philadelphia chromosome, that stuff comes with CML. It's a quick timer. Boom. Okay. Celiac disease, as soon as you read that, probably just straight away put iron deficiency. For those of you that put B12, you're probably thinking about IBD. So IBD is a bit more associated with B12 because of the fact that, say with like Crohn's, it's often going to affect the ileocecal junction, and that's where your B12 absorption typically happens. Whereas with celiac, since it affects the duodenum, that's where the iron absorption happens. And so that's where you become iron deficient in celiac when it's not well managed. If it's well managed, then actually it doesn't really matter that much. And then for those of you that put anemia of chronic disease, probably the only thing is the fact that it's a recent diagnosis. If this was an old patient on like a bunch of medications, then maybe you might lean towards anemia of chronic disease. But yeah. One more. You guys will get the slides after everything, so you don't have to take photos, by the way. Again, another 50-50 split. This one's kind of mean, I guess, because it really boils down to just how prevalent these are. So hemophilia A and von Willebrand disease are both going to be decreasing your clotting. So it'd be more to do with easy bleeding, hemathurosis, less so to do with an increased risk of VTE. As for antithrombin 3 deficiency and factor 5 laden, they do both increase the chance of clotting. However, factor 5 laden is just at the end of the day way more common. And I was shocked about this, like 1 in 20 to 25, like that's crazy. Anyway, that's all for me. If you guys have any questions, feel free to ask me now or DM me or don't. I don't really.
Thank you, Rakeith. So now I think we are going to hear from our sponsor for today, and we'll have Ashita talking on behalf of BMJ.
I thought you guys would have the slides.
Yeah, can you say? And we'll also have food shortly, but we're just waiting on the food to be delivered here. So we'll see when that comes.
She would have sent it too, but I guess not.
No, yeah.
I don't know what's going on. Just maybe I just saw this.
I was just sat with Carrie and both of us like, what is going on right now? I don't know.
Is it, which one is it?
That's the, yeah. And I think I screenshotted all of your speaker notes.
Oh, excellent. Oh, sorry. Do you want to?
No, it's all good. I've got them all. Okay. Hi, everyone. So you're quickly going to hear from BMJ. I'll just quickly be talking about. Okay, there we go. Just quick. There we go. I'll just quickly be talking about why we should be using BMJ more. So there we go. So what is BMJ best practice? It's ranked one of the best clinical decision support tools for health professionals worldwide. BMJ best practice provides step-by-step guidance on diagnosis, treatment, and prevention. The generalist point of care tool covers 90% of most commonly occurring diseases and high-risk associated comorbidities. It has an easy, practical, action-oriented structure reflecting the clinical workflow. Does everyone actually use BMJ? I'm actually curious. Yeah? Okay. Okay. So you're quickly going to hear from a few students that actually do use BMJ, and for many, it's their go-to resource for helping with either PBL or CBL. I know personally in Traralgon, we make our own PBL, so it's very useful. Prepping for exams, research for assignments, clinical practice. It's basically the trusted second opinion when it counts, as well as like things like yeah, AMH. So these are basically the key features. I'll let you guys quickly read that on your own. Just some summaries, some procedural videos that are really cool, some tables that offer like the algorithms. I don't know if you guys have read the treatment algorithms, but it's the only thing I use for management personally. There's a bunch of references as well as the app being online. Okay, so this is basically how to access BMJ. So on campus, you just connect to the uni Wi-Fi and then go straight to the website. If you're off campus, then you can access it either via the Monash website, or you can just search up BMJ best practice. And you can create your own account and set up your own app. And this way you can access it offline as well during board rounds, which is really helpful. Yeah, and this is basically how to set up your profile. It's not too difficult. And yeah, hope you guys use BMJ in the future. That's me done.
Thanks, everyone. We'll just be waiting for the food to come. It should be here very shortly. And for the people on
Alright, I think we'll get started. Okay, everyone. I think we've sort of plateaued at our numbers for the Kahoot, so we'll get started. Yep. All right, everyone, here we go. Year 3B, and oh yeah, and then just. Okay. All right, here's the first question. All right, I think I've got everyone actually. How do I go next? Oh. All right, everyone. So the answer here is 25% dextrose. As you can see, the patient has hypoglycemia, so you want to raise the blood sugars up. The best way to do that is by using a small volume of concentrated dextrose, and that's going to get their blood sugars back up to a reasonable, or back into that normal range. If you're outside of hospital, you would use IM glucagon, and you might have heard of jelly beans being used, but because the patient's drowsy, it's not really the best, and definitely in hospital, you want to use more concentrated dextrose. The 5% dextrose, you wouldn't really use in this situation because, again, you want to rapidly increase their blood sugar levels. Any questions about any of that? No. Oh, yep. Not really. I think what I want to just really emphasize in this question is if they have really low blood sugars, use something like concentrated dextrose to increase it. Don't use jelly beans. Don't use IM glucagon because you're in hospital and you have better, like you have a better solution to that problem. Does that make sense? Like you don't really need to worry about whether it's hypotonic or isotonic or any of that stuff. Yeah. Anything else? No. Okay. So go next. And yeah, I've already explained this, so it doesn't matter. Okay, and then click. And click again. Yeah. All right, Cushing syndrome. Okay, so submit your answer quickly because I'll press skip. Quickly, yeah, okay. Okay, so, okay, so we'll go down from A, B, C, D. So Cushing's disease is an adenoma of the pituitary gland that secretes ACTH. And that comes under the syndrome of Cushing's, or that comes under Cushing syndrome. Cushing syndrome, one of the complications is osteoporosis, which is associated with decreased bone density. We'll leave C for now. Cushing syndrome is a complication of prolonged or long-term steroid use, not methotrexate. And Cushing syndrome is associated with small cell carcinoma of the lung, as opposed to squamous cell carcinoma, which is associated with hypercalcemia due to the PTH-like hormone. So I'm pretty sure I went over the complications of Cushing syndrome in the lecture that I did. But again, there's a lot of complications: cataract, glaucoma, osteoporosis, obesity, and one of them is also peptic ulcer disease. And in some cases, you can also use PPIs to prevent peptic ulcers. Maybe it was a little bit unfair to ask you to know that information, but I think that you should be able to exclude the other options and then come to the answer of C. But again, it is about learning, and it's better to make the mistake now as opposed to in the exam. All right, next. Any questions? No, okay. Next, and I'll click next again. Okay, I've explained it. No one has any questions. And I'll click here as well. Okay. All right, submit your answers. Yeah, okay, so again, pretty clear divide. Yeah, sure, thank you. Okay, so pretty clear divide. They have DKA, so more dextrose isn't going to be the answer, and it's a bit of an emergency, so you don't want to just reassure. As opposed to red versus blue, I would suggest, so when I was writing the question, I thought more of a doctor's ABCD approach. So D for danger, R for response, S for send for help, and then airway, breathing, and circulation. So under circulation, you will want to increase their blood pressure to provide a fluid bolus, increase their blood pressure, and then after that, immediately provide IV insulin. Definitely, you have to lower the blood sugars first. Oh, sorry, you have to lower the blood sugars, but you want to address the problem with their circulation as a priority. And then you might have heard of that spider mnemonic that I've got on the screen. And I think the perioperative questions will talk more about this. But essentially, it's saline, insulin, and then you want to use dextrose to make sure that the sugars aren't lowered too much. And then you want to monitor their electrolytes as well. Any questions? No. Okay, good. So we'll go next. And next again. And I've already done this. Okay. All right, I think there's just a couple people left to put in their answers. I'll give you maybe until 25 seconds and then we'll go through it. Oh, okay, perfect. Yeah, so long acting and short acting is basal bolus. That will provide the best type of control. Mixed insulin is more for best control for type 1, sorry. Mixed insulin is more if it's steroid induced. Long acting alone is more for palliative care. And continuous insulin infusion, I'm not sure when you would use that. Okay, any questions? No, okay. Okay. Again, just waiting for a couple more people and I'll submit in about 5 seconds. Okay, so I again, maybe this was a little bit left field. So I do apologize if that's the case. What I'm trying to get at here is they've got type 2 diabetes, they've got hypertension, they've got poor sleep, got a headache that's worse in the morning, the mood's a little bit off as well. What I'm trying to sort of get at is OSA. As a secondary cause of the hypertension. So that's why I've put sleep study as the answer. In the lecture, I did mention some of the secondary causes of hypertension. So like primary hyperaldosteronism, Cushing's, OSA. I probably should have given you the BMI as well. That probably would have made it a little bit easier. But again, I really encourage you just to think like what could the possible diagnosis be? And then from there, look at what investigation you should do. Again, maybe a little bit of a left field question. So I do apologize about that. Any questions about this question? It can be, but I think that would also be consistent with OSA. Yeah. Unless if you've read anything different, then please let me know. But my understanding is that OSA can present with a headache that's worse in the morning because they're not sleeping well. They wake up because of the desaturations during their sleep, and then because they haven't had a good sleep, they wake up with a morning headache. And you also have to remember, like, primary brain tumors aren't really that common in adults. And I've also given you a few of hints as to, 45, you wouldn't really expect someone to have hypertension. You would want to consider secondary causes as well. Okay, thank you very much for your questions. Any other questions? No, okay. All right. Oh, and I just want to remind everyone, it's high blood pressure, which medication, but it's the least appropriate medication. So I'm sorry if you didn't, I'm sorry for not bringing that up earlier. Right, very good. Again, the medications that you would use as first line for hypertension are A, C, and D. So ACE inhibitor or ARB, calcium channel blockers, and thiazide diuretics. That's what ETG and the Australian Heart Foundation says. Beta blockers, you wouldn't really use those because they will cause more peripheral vasodilation as opposed to really lowering the blood pressure. That's something that you might see more in ACS. And does anyone know what the second, actually, I'll just say it. So you use those three agents that I just mentioned as first line, and then if that doesn't work, you would add another of the first line agents. Any questions? No, okay. I'm pretty sure I did go over this more in my lecture, so if you want more information, you can go there. Twice is 21. I will submit in a couple of seconds. Yeah, very good. So Graves' disease, TSH will be low, and the antibody is TSH receptor antibody. Any questions? Right, everyone. I think that's... Yeah, okay. So it's Addison's disease. Addison's disease is a disease of the adrenal gland and not being able to produce enough cortisol. So if cortisol is low, ACTH should be high. So that's why the answer is C. And also just note the family history of type 1 diabetes, Graves' disease, and celiac disease. They are all associated. And I think rheumatoid arthritis as well. Any questions? No, good. Not good, but. All right, everyone, submit your answers, and at 10 seconds, I'll submit or go next. Very good. Again, I'm pretty sure I covered this in the lecture. Ezetimibe will reduce LDL-C levels. And then just know what agents you use for hyperlipidemia and hypertriglyceridemia. Yeah. Any questions? No. Okay. Okay, this is the last question, and I've just been informed that there is some GYG left over at the front of the room. So don't go now, but go after the question, please. Oh, okay, so a bit of a split actually. Yeah, so it looks like we all know that bisphosphonates have a risk of GERD, so you want to sit up 30 minutes afterwards and have it with a full glass of water. Denosumab is a subcutaneous injection given, I believe it's every 6 months, but either way, it's not an IV infusion. The first-line agents are bisphosphonates and denosumab. Teriparatide is not a first-line agent, so remember anti-resorptive is first-line, bisphosphonates and denosumab. And definitely bisphosphonates and denosumab have an increased risk of atypical fracture. So atypical fractures means like femoral shaft fractures, for example. And the other risk, if anyone remembers, of those two agents is osteonecrosis of the jaw. And yeah, that's really, I think, the key information that you need to answer that question. Does anyone have any questions about anything? Online, maybe? Yep. Sorry? To be honest, I don't really know. I think it's because the bone density is already low, and then the way that they remodel the bone is different to how it normally might. Yeah, I'm not really sure why, to be honest. I just know that that's one of the two main risks. Any other questions? All right, thank you to that person who private messaged me in the chat. Appreciate it. Anything else before I go? Oh, wait, did everyone see it? Oh, damn it. Okay, any questions? No, okay. Yeah, and I also had like a Google form at the end of the lecture, and someone said I didn't talk about obesity, thyroid nodules, and like pituitary cancers. For obesity, really, we had a lecture on it, and pretty much it was about like the non-pharmacological mainly. And then there's also like the newer like GLP-1 agonists, like semaglutide. I don't think you really need to know much about like the surgeries. I think that'd be, you know, even if it comes up, like probably not worth your time in these last few weeks. For pituitary, like adenomas, I think the buzzword is really bitemporal hemianopia, and then just think about like what the hormone would do. Like if it's prolactin, for example, or if it's ACTH, it'll be like Cushing syndrome. And then with thyroid nodules and cancer, to be honest, I haven't really seen many questions about it. But I mean, have you had your pathology exam yet for endo? No. Yeah, it'll be this week, yeah. So I think really for the pathology side of things, that's already would have been covered. And then the main investigations are ultrasound, FNA cytology, and then just surgical resection and all that sort of workup for a suspicious thyroid nodule. But yeah, thank you very much. And feel free to message me if you've got any further questions.
All right, we'll reveal the winners. All right, we're moving on to perioperative medicine.
Just quickly say hi.
Oh, I'll just.
Yeah, much better. And they see the slide. Yeah. They had a break. When was their break?
It was like 12 to 12.
Oh,
They had a
break.
Yeah.
Okay. Hey guys, I'm Ness. We're Ness in one of the final years, and Hi, I'm Katrina. We're going to be running just 10 questions of peri-op. I know it's been a very long morning for you guys, so we'll keep this short. Please do stop, put your hand up and ask questions if you have questions from each. Wait, how is Ness logged in? That's not me. It's probably one of my mentees. If you have any questions from our questions, please put your hand up and ask. These are very high yield questions, and it's really important that you understand why the correct answer is the correct answer. So please don't be shy.
And the questions are going to be easier than endo, don't worry.
Yeah. Don't ask me Yeah. I think like C roles, yes. Alright, am I asking? Do they want us to read out the question? Have people been reading out the question? No. Yeah.
30 seconds, guys. We're about to start. Could have checked your phone. All right. All right, let's get started.
Great. So what kind of drug is empagliflozin? Yeah, so what are we thinking is happening here? Sorry? UTI? Could be with the abdominal pain. So we have a 51-year-old male who's had abdominal pain, nausea, vomiting, and the VBG is abnormal. Now, look, I feel like in the exam they might even give you some more information, but what kind of process are we worried about going on here? So hypoglycemia? DKA? Euglycemic, yep, DKA. So it's kind of like a buzzword, but when someone's on an SGLT2 and they're fasting, so they're off it, this is the buzzword. So SGLT2 can cause euglycemic diabetic ketoacidosis. So their sugars won't change, but they'll have a DKA picture. So for your exams, SGLT2 equals euglycemic DKA, and metformin would cause a lactic acidosis.
So it's important to know that you should stop these drugs at least 3 days prior to surgery in order to reduce the chance of euglycemic DKA. In terms of all the other the medications for diabetes, like metformin, you just stop them so on the same day as surgery. And this came on our exam last year, so please know it.
Lactic acidosis, yeah.
Yeah. Cool. Does anyone have any other questions? Nice. Next. Okay. 5 seconds left. Ooh, mixed picture. So the keyword here, is like best describes her presentation. So it is true that she came into the emergency department on opioids because it says that her pupils were pinpoint. Okay, so that's a buzzword. However, the consequence of that is that she had a respiratory depression. She had a low GCS, so she lost her airway reflexes, and she probably had an aspiration event, which led her to have an aspiration pneumonia.
Just want to clarify, guys, for your actual exams, they probably will be a bit more specific in terms of presentation to ED versus current presentation. So if you read pupils pinpoint, party attire, and thought opioid overdose, don't worry. I thought that just now, and then I was like, yep, this is aspiration pneumonia. So it wouldn't cause your decreased oxygen sats and the fever are very classic of that picture.
And just a quick question for you guys. So if you had the patient who you think is having an overdose on any opioids, what's the reversal agent for that? Good. Naloxone. Good job. Okay, amazing job, guys. So, so the correct answer is to call a code blue and to open the neck sutures. So does anyone know what's going on here? Okay, so you might have seen it like in the past exams as like post-thyroid surgery. So this like type of surgery is so it's a spinal surgery, but they go in through the front of the neck. So he's at the same risk of hemorrhage into the pretracheal fascia. So that's why he's suddenly having stridor and he's having sort of trouble breathing, is because there's there's a whole bunch of blood that's pooling there. So the correct answer is to pretty much to relieve that pressure and to open the sutures, because if you don't do that, he's just going to asphyxiate and die very quickly. So you need to do that like extremely quickly. So you can't wait for the registrar to come, and a CT like isn't going to help you. And does anyone know why it's a code blue and not just like a Met call? Yep. So you need like anesthetics or ICU to come and like intubate, because this is like a threat to the airway. He can quickly just die, basically. So does anyone know what type of hemorrhage this is? If you saw the lecture. So it's not a secondary hemorrhage because it's within the first. Oh, sorry. Yes, it's going to be secondary because it's on day 2. So it's after 24 hours. That's correct. Yeah. And there you can see the pretracheal fascia over here. So it's the same concept like with a thyroid as a surgery as well.
Okay, guys. So the correct answer is pericardiocentesis. So what is a medical emergency that's happening right now? What's the name of it? Tamponade. Did I hear tamponade? And do you guys, so what in the stem makes us think this is tamponade rather than a really bad heart attack? Bextriad, yeah, exactly. So I don't know if everyone's heard of Bextriad, but just to go through it, it's low blood pressure, muffled heart sounds, and distension of your JVP, your jugular veins. And so this is a medical emergency. This can cause someone to arrest, one of the reversible causes of arrest. And we have fluid building up in the pericardial sac. So we need to relieve that pressure around the sac. And we do that by putting a needle in and doing a procedure called pericardial centesis. So like centesis, like draining fluid around the heart, the pericardium. I don't know if you guys have seen the table. It was very popular in third year to learn about the different risks post AMI. So especially at week 1, she's at risk of ventricular wall rupture, blood leaks, which can cause pericardial tamponade. Yeah. You could repeat a PCI if they had ongoing ischemia, but in this case, the Bextriad points us to this picture.
right, good job, everybody. So the answer here is A. So basically, so this lady is having a quite a common complication, which is post-op nausea and vomiting. Does anyone know the risk factors that she has? She has a few. So you can say one. Young, yes. Female, non-smoker. There's two more that I can see. Sorry? Yep, so she's having, so it's either like laparoscopic or like gynae surgery in particular for some reason increases your risk. And there's one more. It's got to do with the anesthetic she got. Yes. All right. So the volatile gases increase your risk of post-op nausea and vomiting compared to propofol. So can somebody who picked A explain why they picked A? How should I say? Good. Okay. So it says here that she has had a bowel obstruction. So you want to keep her on like bowel rest, essentially. And you can't give her this one or domperidone because they are
Prokinetic.
yeah, that's the word I was looking for. So you want to give her BC and D as well.
Also totally fine to, especially in third year, even in fifth year, to do process of elimination. So the question's asking what's not suitable. So what would be like contraindicated almost in her case. So on Danzatron for like vomiting, absolutely fine. Bowel rest will never really not be like unsuitable for someone. Like great, you can rest your bowels, and IV fluids, unless they've got really bad heart failure, I wouldn't be worried about giving that. So if you weren't too sure about metoclopramide, but you did process of elimination, that's also a really good way to go about these questions. Cool. Ooh. It's a bit of a tricky one. Very fair in thinking we need to be worried about lung metastases, but the correct answer is PE. So in this case, what are the things that make us think this is a PE? You can just shout out. Acute onset, absolutely. Yep, so tachycardic. Yep, so he's got a malignancy, stage 3 colon cancer, so very hypercoagulable state, the risk factor for developing clots. So if we just do process of elimination, A, pneumonia, he's got, his chest is clear to auscultation, so very unlikely to be a pneumonia. B, lung metastases. That's probably, we're not too sure, obviously, in this case, but it's quite rare to have an acute onset, a drop in SATs, be tachycardic, and have signs of right ventricular strain, like a parasternal heave in lung mets, but definitely a good thought. So with PE, acute onset, got a slight temperature, tachypneic, tachycardic, and the drop in O2 SAT. So we don't know what his baseline is, but 90 is quite borderline. Just because someone doesn't have calf pain, I know it's so classic to think calf pain equals DVT equals PE, but the clot might have dislodged, or not every single PE needs to have calf pain. So don't let that throw you off. Sorry, we tried to throw you off. Does anyone have any questions about this case? Does it make sense? Actually, very quickly, what score do you guys use in clinical practice to help determine how likely it is that someone has a PE? Well score, yeah. And if that's quite low, oh God, never mind. It's there. And why do we use a well score? What's the point of it? What investigation does it help you decide whether you should order or not? CTPA, good thought. What about, so what's your reasoning in terms of the well score linked to CTPA? Yeah, if it was high risk, you'd order a CTPA. I guess the teaching point I'm trying to make here is that you want to do a well score because if it's low enough, then you can do a PERC score and not have to order a D-dimer. Or you can order a D-dimer to help rule out a PE. So do you guys understand D-dimers? Because it's a really confusing topic in third year and I feel like I can go over it really quickly if you want. But you only want to order a D-dimer if you're quite sure that this person does not have a PE. And so you order the D-dimer, it's negative, you send them home. But if you think someone has a PE, ordering a D-dimer is not going to change what you do. You're going to order a CTPA. So this score kind of helps you ascertain that risk. You can check it out on MD Calc. It's pretty handy.
All right, good job, everybody. So you picked up the correct answer. Does anyone know the medication that I was trying to hint at that he's on? Yes, good. All right, so he's on warfarin because he has AFib, but he also has mitral stenosis, so he has valvular AF. So he had a fall with head strike 2 days ago, and now he's starting to have some weakness on his left side. So he probably has a subdural on his right. So let's have a look. Okay, so that's what you would expect to see. So in terms of the reversal of the warfarin, can anyone tell me the factors that warfarin would inhibit? Awesome. So it's 2, 7, 9, and 10. Right, so you give vitamin K to reverse. You can technically also give like fresh frozen plasma because it does contain some clotting factors, but the main first one will be as vitamin K and then the fresh frozen plasma. Yeah. Any questions about that? Digifab is for digoxin, and you're not going to give him as packed red blood cells because he's already bleeding.
Oh, fantabulous. Great. So this is a really old person post-surgery who's quite delirious, so confusion, agitation, disorientation. Yeah, she's got a catheter, and so they're high risk of getting infections. It's really important that we consider why someone is delirious in hospital. So I know that only one person picked pneumonia, but I also think that's still a really good thought. Like, you want to ensure they don't have a chest infection or a urinary infection that's causing this. Yeah. Causes of post-op fever, very high yield. Have you heard of wind, water, walk, wound, and wonder about drugs? So she's in a good time period to worry about urinary causes. Any questions? Cool. Great. So 42-year-old female in ED. She's had local wound care and suturing, and now she has these really weird symptoms. So local anesthetic toxicity. Does anyone know how many, actually, you know what, we don't have time. You can learn about it in fifth year, how many mils per kilos of local anesthetic you can use. Again, process of elimination. She's got really weird symptoms. She's got a metallic taste in her mouth, ringing ears. And so we're worried about local anesthetic toxicity. You can use SAMS as a good way to remember the different sort of complications of it. So difficult, like numbness of the tongue and lips, altered central nervous systems, the restlessness or drowsiness, muscle twitching, and you can even have seizures. So the treatment for this is lipid emulsion therapy. But it's quite rare to see this in clinical practice, because if someone requires lots and lots of local anesthetic, they most likely go to theater for a washout rather than injecting heaps of local anesthetic in that setting. So yeah, also process of elimination. Don't think every female patient has anxiety or it's a panic attack. It can be something more serious than that. And yeah, it doesn't fit the other options.
Five more seconds. Okay, so can anyone tell me what's going on in this scenario? Good. All right. So it's DKA. So I just threw in the fact that he has type 1 diabetes at the end of the question. So he's had gastro for 3 days. He's been vomiting. He's dehydrated. He is sick. So he is in a state of DKA. So the investigations to order for DKA. So just remember, so diabetic, so sugars, so K for the ketones, and then A for the acidosis. Right. C1 and venous blood gas. You don't need like an ABG. It's just harder to get. It's bloody. and you like only really get it like if you're like trying to find out the oxygen levels properly. So that's not the focus here. So you get a VBG and you can run it really quickly and you can diagnose this guy with DKA. Yeah. Any other questions?
Next. Yep. So I don't know if you guys, this is the last bit of our section, but treating DKA, always remember the acronym SPIDER. So S for saline, P for potassium. So it's really important that when we treat DKA, we eventually want to give IV insulin, right? Because they don't have, their body's not using insulin properly. So we give IV insulin, but with insulin, the cells draw in potassium quite quickly. And so if we don't replace the potassium, that's what's going to kill them, not the DKA, the potassium being super low and giving them an arrhythmia and then dying. So it's really important that we replace potassium, give some IV insulin and some dextrose. But in an exam or in an OSCE, when you don't have much time, you can just say, I'd follow doctors A, B, C, D, make sure that I'm giving them potassium, saline, and dextrose, and I'd escalate for senior help. And that should cover you. Cool. In kids, it's really important to do this really, really slowly. You learn in peds next year, some people can die of cerebral edema if you treat their DKA too quickly. So it is quite a serious thing. Okay. Any questions about that? Cool. That's us. Oh, wait, the winners, the most important. Well done to, I. So number 3, Triple C. And A, good job. Wow, we should got all the vowels up.
Thanks, guys.
Thank you. We'll move on now to cardio.
I guess you've probably seen it for the most part.
Actually done cardio from the like this side of it.
It basically runs like a slideshow. Yeah, basically. So there'll be like around 60 people around.
I love your outfit. I feel like every time I see this,
Hey, Bill.
it's so sweet.
Oh, sorry.
Bryson. Great. Yeah. What? But it's a small. Who's that?
No hiding or no showing questions or
People yeah, but he's okay. He's got 2 times. Are you okay? I'm good. Yeah. Okay. Yeah. No, he's pushing from yeah. So that's yeah. We were walking this morning. So if you're out about around 1 o'clock. Wait, you looking at
All right, we're going to start soon. Before we do, can everyone get up and do a couple little jumping jacks, get the blood flowing? Some of you are looking at me like you're not impressed at all. We're doing cardio. You got to get the heart rate up. You've got 20 questions coming up, so get your sips of water and stuff now.
2026 February. Here, not any time. It's like same time and you go about the other. Yeah, I know. It's like, oh, yeah, he should be down there. I thought you meant his dog was here as well. I'm so hard. He would be quiet. He would just be so excited. He'd try right.
All right, 30-second countdown.
I'll see you later. Oh, I'm gonna head off, but I'll
All right, let's get cracking. All right. Very well done overall. So, yep, the answer for this one was a 3rd-degree block. So I've just circled in the P waves here so you can get a better idea in case you couldn't see them. I think it's important with this question to realize that sometimes the P waves can be a little bit hidden in other things going on. So if you do see other little bumps and you're not too sure if it's 2nd-degree type 2 or a 3rd-degree, look for those little divots because sometimes P waves can be hiding. So here you can see the P waves are regularly spaced out and 0 relationship between them and the QRS, which is why this is a 3rd-degree. Also, if you take in mind that I only gave you lead 2, probably going to be like a rhythm related issue because you can pick that up with just lead 2. All right. So everybody said that answer. Good. So let's talk about what kind of heart failure this is. So this is HFrEF because the ejection fraction is less than 40%. And let's just go through what some of these different drugs are. So who can tell me what valsartan and sacubitril is? Arnie, fantastic. What's metoprolol? Yes, everyone knows that one. What's spironolactone? Yeah, one of the potassium-sparing diuretics. And dapagliflozin? Beautiful. Fantastic. So that's the ABSS. So these are the 4 medications that actually improve mortality in HFrEF, and you should start them at time of diagnosis. Obviously, furosemide can be really helpful in getting someone stabilized, but in the long term, it will not improve someone's mortality. Oh, sorry, sorry, sorry. Beautiful. So let's talk about this one in a bit more detail. What's the diagnosis? Yeah, rheumatic fever. So what criteria do we use when we're diagnosing rheumatic fever? Jones. And what does Jones stand for? What's the J? Joints. What's the O? Yeah, it's the heart. And what does the heart stand for? Yeah, carditis in general. Could be peri, could be Maya. What's the N? Yep, nodules or nodes. What is the E? Yeah, erythema marginatum, so that's that rash there. And the S? Yeah, synonym chorea. So I've got those ones on the slide. So if we're counting up the factors that this person has, they've got one major here, one major for the erythema, another major for the joint pain. So they've definitely ticked off the first half of the criteria. But the second thing is you have to prove that it's a strep-related infection. So the school sores and the sore throat are pretty likely, but we actually have to find that they have a raised strepsilicin O titer, or they have to have a positive swab of their throat if they were having strep throat. There's the little slide for you there. Okay, so the point of this question is to consider the CHADS-VAS criteria for this person and also consider how long he's been having the AF. So sorry, I should have put it in the actual time, but let's say since 11 p.m., we're going to assume it's quite short period. He's just presented to the ED. But in this case, you've got a 52-year-old man. He's got no medical conditions. In this case, he's actually not going to benefit from having any anticoagulation unless you need to go to the point of actually treating him for the AF. But here are your CHADS-VAS criteria. So your heart failure, hypertension, over 75, diabetes, stroke, vascular disease, all that kind of stuff. So in that case, he scores a 0. So he doesn't actually need any anticoagulation at that stage. If we're going to go to the point of doing your electrocardioversion, then you would likely want to rule out that he's got a clot. But again, it takes into consideration how long he's been having symptoms for. In this case, it's very acute. And most likely for this person, it was alcohol-induced AF. So it'll just go away with time. And do you guys know what kind of AF we call that when it just goes away? Yeah, paroxysmal. Yeah. Ooh, tricky, tricky. This one does look for some parts like it could be torsade de pointe because I get what some of you are probably looking at, that it has a little bit of oscillation. However, I would always go back to looking at lead 2. And in this case, the tiny voltage and the fact that lead 2 is consistently in that fibrillating type pattern is what makes this VF. Okay, cool. Most people got this one right. So it's tricuspid valve, and most likely bug is going to be Staphylococcus aureus. Why is it the tricuspid valve that we're thinking? Yeah, IV drug user. So if you think about it, if you're giving yourself IV drugs, the first valve that the blood is going to cross, the one that's coming into the heart, is going to be your tricuspid valve. So that's the first spot that the bugs have an opportunity to attack. And keeping in mind that Staph aureus, we know it's on the skin, it also can damage any kind of heart valve, not just pre-damaged valves. So considering tricuspid normally doesn't get damaged, you actually can get it damaged from that bug in particular. When we're talking about the Viridans streptococci, what source is that most likely coming from? In Monash Examland. Yeah, dental, fantastic. So if someone recently had some dental cleaning or dental procedure, you might be more suspicious of that one. It's less dangerous and more likely to cause you to have like a subacute presentation. So the other clues here was this was a 5-day, so that's considered acute, which you're more likely going to see in a staph aureus. Fantastic. Why does he have hemoptysis? Any ideas why he's got hemoptysis? Yeah, exactly. You get septic emboli that go off into the lung. And think about it. From the tricuspid valve, where's the blood going to next? To the right ventricle and then to the lungs. Yeah. Where else can you get septic emboli going? The brain. Yeah. Say that again. Sure. Yeah, you could. I think that's a little less common, but yeah, could. Mesentery. Yep. Yeah, you can get into your hands. And what sign is that called? Janeway lesions, beautiful. Yeah, you can also get it going into your joints. So that's when you can get septic emboli in the joints causing joint pain. You can also get in your kidneys. You can get some hematuria. Just about everywhere. Oh, this is not the correct answer. The correct answer is muffled heart sounds. That's okay. I think I might have made a mistake on that one. But that one person, you're really on the money. All right, guys, what's the diagnosis? Music and Mexic totally stole my thunder with this. Tamponade. Yes. Why is it tamponade? Yeah, Beck's triad. So we've got distended neck veins, a low blood pressure, some trauma in the history. That's the last part of Beck's triad. Yep, well done. All right, so this one is PR depression. The trick with this one was it wasn't global ST depression, it would be elevation, and you get like a saddle ST pattern. So let's go back. What's the diagnosis for this one? Pericarditis, fantastic. So you have young person, that's pretty classic. Recent colds, that's your viral causative factor in the background. Sitting forwards on the chair and avoiding deep breaths. So that's to reduce some of the pleuritic chest pain or pleuritic, I guess not pleuritic, pericarditic pain. Also, apologies in the lecture that I recorded. I made a mistake on that, but I've updated the slides to reflect that properly now. So thank you to the person that pointed out that I made a little mistake there. And friction rub. Perfect. So this is the PR depression. That's the saddle ST elevation. And you get that globally. So you get that in all leads, not just any particular lead. Just going back, what kind of things can cause QT prolongation? Yeah, drugs. What kind of drugs? SSRIs, yep. Lots of antibiotics as well. There's kind of a like mnemonic type thing. Most things that start with anti can cause QT prolongation. So antibiotics, antidepressants, antipsychotics. But you'll learn a bit more about that in 4th year when you're doing psych. Fantastic. Okay, awesome. Most people got this one right. So this is a flow murmur. So flow murmurs happen when you have essentially excess blood that the heart's pumping, because you get some turbulence from having that increase in blood. So some of the common buzzwords to keep in mind with this is someone that has iron deficiency or any other kind of anemia, because you compensate by producing more blood and increase blood volume to compensate for your low red cells, especially with the iron deficiency. You'll have like lots of small red cells. And the other ones, I think pregnancy, you can get that as well because your blood volume increases. And then often we'll see it in people with stimulants. You can often see it with people with the palpitations as well, because that sometimes is a Monash buzzword for they've been using stimulants or caffeine or anything like that. Also, I didn't put any specific location for where you're auscultating this murmur as kind of a clue that it could be a flow murmur, because flow murmurs you can hear in a variety of different places. Often it's the left upper sternal border, but it can also radiate to axilla, radiate to the back, and you can kind of hear it in different areas. Excellent job. So the key here was cardiomyopathy. So hemochromatosis is just a risk factor for getting cardiomyopathy. You can get dilated or you can get restrictive cardiomyopathy with hemochromatosis. So you get the restrictive when you get those iron deposits. I actually don't really know why you get the dilated, to be honest. We'll just roll with that. What's the other kind of cardiomyopathy you can get? Not from hemochromatosis, but in general. So you've got restrictive, yep. You've got dilated, and then there's another kind. Obstructive, yeah, so that's like your Hockham. Good, most people got that one. All right, so this is venous insufficiency. So what happens with venous insufficiency is you don't get the venous return, so you get like blood pooling, and then that can cause a hemosiderin staining, because if you think about it, you've got stagnant blood in your veins, the red blood cells start to slowly break down, and then the heme that's inside the red blood cells eventually will deposit right into the skin. So I think I've got a picture here. Yeah, so it's like this brownish coloring. So these are all signs of venous insufficiency. You also get pruritus, a little bit of warmth from, again, that dilation of the venous supply. And you can get some edema, varicose veins, all that classic stuff. Do you guys remember the other? So the 5 Ps is what we often use to refer to for arterial damage, so like PVD. Do you know what the other 2 are here? We've got pallor, we've got pulseless, we've got hair loss, there's a couple others. Paresthesia, yeah. Perishingly cold, beautiful. And sorry, there is one more P. Pain, pain. Oh, I made this way too easy for you guys. You nailed it. Awesome. Yeah. So that was aortic stenosis. So you get your triad of dyspnea, chest pain, so angina, and fainting. I forget the proper term for fainting. I'm having a blank. And yep, you get your crescendo, decrescendo, systole and ejection murmur, and it radiates to the carotids. Fantastic. So, and then the bonus question here was it should be lateral leaning forwards. These will definitely come up on your exams, so do know them. It looks like you guys do. Cool. There was totally a typo in this. Sorry, guys. So that one that said lateral should have said anterior. My bad. So that one was a V2, V3, and V4 elevation in the ST segment. And you're noticing that you're not getting that in other leads so much. We are getting the reciprocal changes here. You can see a little bit in lead 3 and a little bit in lead 1. And yeah, so it's not a left bundle branch block. I don't know if anyone actually put that. Maybe one or two. So there's no change to the QRS. What would we see in a left bundle branch block in terms of the QRS? What's the little funny name we use to remember left bundle branch blocks? Yeah, exactly. So you get the little W and M shapes. Cool. Awesome. Yeah, this was not a trick question. It should be that you're giving this person lifestyle modification. So everyone needs to think about that SNAP W. So smoking, nutrition, activity, weight loss. What am I forgetting, guys? Alcohol, thank you. Aspirin because they have angina and that's part of the prevention for having worsening symptoms. Atorvastatin because everybody needs to be put on cholesterol medication, especially since she does have high cholesterol. And an ACE inhibitor definitely. It'll help with the angina, but it'll also help with her baseline hypertension. Excellent. Yes. So the second line hypercholesterol medication is ezetimibe. But in this case, you're going to add it onto the atorvastatin. I think it might be tempting to switch to it, but they work synergistically together. So it'd be beneficial to add it on top, especially since his cholesterol levels are so whack. So go with that. Your next one would be to put him on a PCSK9, but that would be through a specialist. And that you usually add on top of the other medications anyways. Do you guys know from pharmacology what fish oils are actually helpful for? Like what kind of cholesterol elevation? Pretty sure it's just the triglycerides. So they have some benefit to lowering your triglycerides, but they don't do anything for LDL and HDL. All right. Now this one, sorry, I made a late change to this. This was my fault, but should have actually been the red one here. So oxygen is kind of debatable. However, in this case, I didn't say that the person had any reduced oxygen sats. So we don't generally provide oxygen to everybody that's having an AMI. Do you know what the cutoff we use is for them actually getting oxygen? Below 92, yeah, exactly. So if he was below 92, yes, he'd get oxygen. If he was not, he would not get oxygen. But otherwise, he definitely needs the other things, the serial ECGs and troponins, cardiology referral to get his actual treatment. Depends what they're going to decide to do, if that's going to be a percutaneous intervention or if he's going to get fibrinolytics if he's from the country, and definitely needs morphine to manage the pain. So alteplase was one of those fibrinolytics. If you're seeing a stem that has the person is from a rural area, you might be considering that. Okay, this one was too easy. Good job. So metoprolol, beta blockers, we want to avoid because this person has asthma. Otherwise, the other ones would likely be appropriate. What ADRs can you get with ramipril? I put obviously the bilateral renal stenosis and bradykinin cough, but there's one other big one that can cause someone to actually go to ED. Yeah, angioedema. So you can get this really bad swelling of your lips and your face, and ACE inhibitors are the #1 medication that can cause that. So in this case, ACE inhibitors and ARBs are both first line. However, you don't get the bradykinin cough as much with ARBs. So if you're going to put someone on a blood pressure medication, may as well just put them right on the ARB instead of trying them on an ACE inhibitor and trying to wait to see if they get that cough, because I think it's actually about 20% of people will. Excellent job. Why is this not an umbilical hernia? Yeah, it's pulsatile. That's right. That's right. Also, this person has some risk factors. What risk factors does he have for a AAA? Smoker. Yep. I think someone said hypertension. He's a man as well. Yep. Who knows what the management would be for this, keeping in mind it's a 4 centimeter AAA? Do nothing, kind of. Yeah, so it's kind of debatable. So he is having some symptoms. So because he's having symptoms, you might want to investigate that a little bit further. Obviously, if someone's in pain from something, we want to help treat that. But generally 4 centimeter ones, if you get their hypertension under control, you can do more conservative management. Otherwise, you'd stent it. I guess like in general, cardiology referral is the way to go. Okay, let's have a chat about this one. What do we think the diagnosis is, just based off of the history, and I guess now seeing the right answer? Any ideas? Yeah, I think I heard myocarditis. So that's what the presentation was supposed to be here. So let's talk about why. So let me get my little pen up. This is kind of fancy. All right, so we have oh no. Maybe I can't use my pen as well as I thought. Oh, wow. Okay, thanks. Oh, that's cool. All right. 20. Oh no. Close your eyes. Close your eyes. Okay, I'll just talk about it then. So we have a 28-year-old male. So myocarditis is more likely to be present in younger people. Young men in particular, more likely to get it. I'm not sure if they'll do this on exam questions now, but there was some myocarditis after getting some COVID vaccines and that sort of thing from the immune response. So they might put that in as a potential like trigger event. But otherwise, you can get a viral infection that can then trigger the myocarditis afterwards. It does present with chest pain, shortness of breath, and palpitations. If it gets any worse, you can get heart failure symptoms as well. Most of the time, it does just self-resolve. So in the situation here, he had a fever and myalgias the week before. What do we call that when people get those kind of symptoms before other symptoms come up? Yeah, prodrome, beautiful. And the key here was that there were no particular findings on the cardio-resp exam. So he doesn't have a murmur, which is why this is unlikely to be endocarditis. And his other vitals are normal. So again, pretty well other than just the symptoms that he's having. So the reason that we're going with this group of investigations, the BNP, troponin, and CKMB will tell you if there's actual myocardial damage, which will be useful. The anti-strepsilicin O titer, not as helpful because he doesn't have any of the other Jones criteria that would make you think he's in that range. And also, if you remember back to the rheumatic fever question that we had before, it was a young person. You're usually going to get it under the age of 15 if you are going to get rheumatic fever in Australia. The option A is more of like a screening test, and I guess you'd use that in like GP land for people in general to see how their health is, but not as much use here. Any questions about that one? All right, fantastic. And if you saw the answer for question 20, no, you did not. Okay, we're gonna move on. Yeah, well done on this one. Heart failure is one of your R1s, and I think this is definitely a fair exam question. I've seen it come up on some other exams in the past, so it would be good to know them. So New York Class 1 is no symptoms at all. New York Class 2 is, oh, let's go back. No, I can't. All right, Class 2, you have mild symptoms during physical activity. 3, you would get symptoms during the household chores. So in this case, the vacuuming, hanging, the laundry, those are pretty physical activities. But I put cooking as not really that physical and fine at rest. And New York 4 is symptoms, totally at rest. Good job to everybody. I'm sorry if you were missing out on one of those questions because the answer was wrong on our end. You get a high five from me, from my heart. Thanks, everybody. Thanks for organizing everything today.
Hello. All right, moving on to MSK. Thanks, Em. Oh, what's
Yeah.
this?
Is it a PowerPoint? Yeah. Okay. I think the slides kind of doubled up. Okay. That's fine. This one. Oh, wait. So are you controlling this one? No, you control. Oh, so you. Yeah. Oh, yeah. Yeah, so basically, when you're ready, yeah, you have to go next, and then when the question comes, just move to the next slide on this one. Yeah, because the question comes. Okay, cool. Yeah, is it just I'm not very technologically sound. So that's okay. Who is F. Beb Diddler? Okay. All right, we'll get started in a sec. Is everyone ready? Okay, true. All right. All right, lock in, everyone. Oh, so you go to the... Sorry, it's a bit of a long one. Good job. Cool. So what's going on here is we're trying to kind of look at, I suppose, the management of an acute gout attack, and not necessarily how we manage the attack itself, but more so the guidelines regarding the allopurinol. So first of all, we'll open to the floor. What are some risk factors for gout? Oysters, yeah. So like the rich man's diet's what they call it. So food rich in purines. What else? Yep. So lots of medications, but particularly some of the diuretics as well. Cool. And in this case, yeah, so even when we do have an acute gout attack, we continue on the same dose of allopurinol. So allopurinol is kind of a preventative measure, or prophylactic measure rather, that people who suffer from gout attacks use. And increasing or changing the dose during an acute gout attack can actually increase the subsequent risk of another one. In terms of how we manage an acute gout attack, what medications would you use? Yep, colchicine. Yep, NSAIDs as well. Cool. And you can also start allopurinol during acute attacks. So if someone's not like previously taking it as a form of kind of prevention, and if someone has an acute attack, you can kind of start it then as well, along with the other acute management. So NSAIDs, colchicine. Cool. FPEV's victim. Oh no. All right. Good job. So in terms of the history, what kind of factors make you point more towards, I guess, a systemic cause of arthritis rather than, an osteoarthritis that's developed over time? Yep, yep. Yep, young. Yeah, so the dandruff and the skin irritation is kind of making you point towards psoriasis associated arthritis. So straight away as well, we can see that the pain is worse in the morning, which is kind of a buzzword for like a rheumatological cause, whereas osteoarthritis and kind of those wear and tear arthritis get worse with movement, whereas rheumatoid and psoriatic get better with movement. And as you can see, the gross kind of picture in the bottom right are kind of some of the nail changes that are associated with the psoriatic arthritis. What are some of the other things or clinical features that you might see in this form of arthritis? Pardon? Yeah. Yep, so you get like big, like sausage fingers is what they call them. Once you see them, you'll never forget them. Yeah, and some of the other features of psoriatic arthritis. So it's the early morning stiffness, the dactylitis mentioned, so like the sausage fingers. And as well, you'd see generally other features of psoriasis in other parts of the body. So for example, here, we've got the scalp dandruff, some of the other rashes as well that you may see. Cool. Nice to see FPEG's victim dropping down. A bit of a tricky one. In terms of X-ray findings for osteoarthritis, what are the kind of the classic signs that we see? Yeah, all the other ones. Yeah. Thanks. Yeah, so I guess the best way to kind of remember the it's a bit tricky when you're actually looking at an X-ray because they do look quite similar. But remembering the loss signs, that's loss of joint space, osteophytes, subchondral sclerosis, and subchondral cysts. And that juxta-articular osteoporosis is kind of a bit more specific to the rheumatoid arthritis. So as you can see just below where the answers are, there's kind of erosion of the bone, and that's a bit more specific towards osteoarthritis and a systemic cause rather than, the wear and tear kind of associated with osteoarthritis. Bit of a bonus question. In terms of presentation, what would make you, I guess, suspect rheumatoid arthritis over an osteoarthritis? Pardon, sorry? Yep, that's a good one as well. Yeah, morning stiffness lasting more than an hour. That's a real good like buzzword, I guess, for rheumatoid. Someone's got to take this victim down. Nice. Good job, everyone. This question's a bit of a buzzy one. Not gonna lie, don't know too much about the crystals, but so in the case of pseudo-gout, you're more likely to see the positively birefringent rhomboid-shaped crystals. It's a tricky one, because of the calcium and the calcification that's kind of occurring in pseudo-gout. So that's kind of like, it's a buzzword kind of question. You don't really need to know too much more about it all. But yeah, so gout has that monosodium urate kind of crystals, whereas pseudo-gout has those calcified ones instead. And that's to do with, I guess, what is deposited within the joint. My goodness, someone. Oh, tricked you guys. Okay, in terms of osteoarthritis, I guess in the kind of like stepwise approach, what are the kind of steps that you take, I suppose, starting at the bottom and then working up as things aren't improving? I'll start picking on people if no one answers. So in osteoarthritis, what's kind of like that stepwise approach that we take in terms of starting low? What kind of treatments do we give? And then as things don't improve, where do we kind of go from there? Yeah. So SNAP W, so weight loss, stopping alcohol, those things that may contribute to it. Physical therapy is also quite important. So hydrotherapy is a good one. If you want to sound, if I want to sound smart, I'll throw hydrotherapy in there. Cool. And then after that, you start to trial medication if nothing's really helping. So in this case, she's trialed. This was kind of where I guess the trick part of the question was. So she's already trialed topical NSAIDs, which haven't really helped. And when the topical NSAIDs aren't working, you then move to the oral ones before you kind of go for the steroid injections. Also, in a woman of this age, it's important to co-prescribe these oral NSAIDs with a PPI just because of the risk of gastric ulcers. But yeah, since it's only been 3 months, she's been trialing the topical NSAIDs, which haven't been working. The next step would be to move to the oral ones. And then if those don't work, eventually would move to the injections. How are some of you answering so quick? Just clicking random things? All right, so this one's kind of testing, I guess, in someone that has rheumatoid arthritis, what kind of things are important to monitor throughout. So methotrexate, a medication taken by lots of people who have rheumatoid arthritis, can cause hepatotoxicity. So LFTs should be regularly monitored. It can also cause myelosuppression. So FBC needs to be monitored too, but that's not an option in the answers. But yeah, in terms of why some of the other answers are wrong, methotrexate can also cause some respiratory issues, but you don't do regular chest X-rays to monitor doesn't affect thyroid function, and also doesn't affect blood sugar. Cool. All right. So based on the stem of the question, first of all, what kind of risk factors does she have? This is a tricky one as well because it's kind of combining endo and MSK. But what kind of risk factors does she have for, I guess, lowered bone density? Yep, postmenopausal. Yep, so she's taken steroids and she has been for 5 months. Oh, those are probably the two main ones. Great. So this, if you can kind of see in the bottom right, it's a bit tricky to see. It's kind of like a approach to treating lowered bone density depending if a patient's on steroids. So again, a bit of a tricky question, kind of combining knowledge of endocrinology and MSK. But because she's 57, so you don't, or if a patient's on a steroid and less than 65, sorry, you do a DEXA first. And if the T-score is less than 1.5, you start an oral biphosphonate. In terms of taking an oral biphosphonate, what's an important thing to remember when you're actually taking the medication itself? Yep, spot on. So take it in the morning and you want to remain upright for like 30 minutes to an hour after you take it. Cool. So yeah, so because of her risk factor being postmenopausal, being on steroids, and then looking at her DEXA score, yeah, so vitamin D, calcium supplementation, as well as the alendronate is an appropriate response. Sorry, this one was really, really mean. I was kind of chuckling when I made it. Great. So in terms of diagnosis here, what are we leaning towards diagnosis-wise? So he's had 3 days of severe right foot pain, swelling and a fever, history of gout, type 2 diabetes. So clearly there's an infective cause going on here. What would make you kind of point towards osteomyelitis versus a septic arthritis in this case? Ulcer? Yep, spot on. So the history of diabetes and the ulcer kind of makes you point towards a diagnosis of osteomyelitis as opposed to a septic arthritis, which would also be, he doesn't really have any, I guess, major risk factors that we've seen for a septic arthritis. You know, there's been nothing like for example. Oh, what are some risk factors for septic arthritis actually? Yep, open wound. Pardon? Yep. And as well, like, surgeries too, and I guess systemic infections that spread. Great. So in terms of osteomyelitis, the diagnostic imaging is an MRI of the affected area as opposed to a joint aspiration analysis and culture that you would do with a septic arthritis. So yeah, particularly that foot ulcer is, I guess, kind of a buzzword or giveaway for an osteomyelitis as opposed to a septic arthritis. And the MRI allows for, I guess, a better imaging modality of the bone and the soft tissues. But yeah, so the persistent ulcer, severe pain in the foot suggests a more complex infection involving deeper structures. So MRI would be the imaging of choice. Sorry, that one was mean. Good job if you got it right. All right, good job. Has anyone here ever torn their ACL before? Not to out anyone, but has anyone done it before? No, that's great. Anyway, so it's an ACL tear. I suppose in terms of the question stem, some of the things that would make you point towards that. It's a football match, so it's a very common injury that occurs amongst footballers. Like Rodri recently for Manchester City, it happened to him, unfortunately. So he was tackled from behind, and then that kind of popping sound and severe pain is kind of, I guess, a bit of a giveaway for the ACL tear, and as well the positive Lockman test. Can you walk on a torn ACL? Yes. And why is that? Yeah, but yeah, that's true. So I guess in terms of ACL, and if you think mechanism of injury as well, the ACL tears most commonly occur with those kind of quick changes in direction. And when you've got an ACL tear, you're actually able to walk okay. So you'll see like footballers and whatnot, they'll tear their ACL and then they'll walk off the field. And that's because they're not actually moving laterally. So they're not really using their ACL as much as some of the other ligaments in that movement. Cool. What I guess as well, what would kind of make you point towards an ACL tear as opposed to a meniscus tear? Yeah, so the Lockman test, and as well, the ACL in terms of the swelling, the ACL, if you do your ACL, it swells up quite rapidly, whereas a meniscus, it kind of happens over a bit of a longer period of time, within 24 hours, but the ACL happens quite quickly. Cool. And what kind of procedure do we do to fix a torn ACL? If you've been on ortho, you can answer this. Yeah, well, what happens in it though? Nice. Yeah, no, spot on. So yeah, so the rapid swelling is a bit more, I guess, specific to an ACL as well as the positive Lockman's test. And that's how they can kind of, if someone goes down with a torn ACL, they're able to kind of, I guess, know pretty quickly because yeah, it's quite sensitive for a torn ACL. So the Lockman. What are some of the other tests that you can do on a physical exam if you're suspecting a torn ACL? Yep, anterior draw. Nice. And yeah, and in terms of some of the other injuries, the LCL and the MCL injuries commonly occur due to blows on either side of the knee. Meniscus tears are quite similar to ACL tears in their mechanism of injury, but again, are more associated with kind of that delayed knee swelling and joint locking. But because of that similar mechanism of injury, ACL tears and meniscal tears can often occur together as well. I think there's like a triad, like a skier's triad. It's ACL tear, meniscal tear, one other thing. MCL, thank you. So yeah, then that's due to kind of that mechanism of injury. Cool. There's one more question that's not on the Kahoot, so I'll just pass it down to the floor. It's a bit tricky if you haven't been on ortho. But an 8-year-old patient, congrats Alyssa, by the way. An 8-year-old patient is brought to the emergency department following an accident playing football. He landed awkwardly on his arm. I'm gonna mute this. He landed awkwardly on his arm, was found to have a fracture. This was reduced, but the patient is still experiencing extreme pain, particularly on passive stretching. His arm appears swollen and he is complaining of tingling in his hand and forearm. Which fracture is most commonly associated with the condition he's experiencing? Yeah, supracondylar, spot on. So in terms of, I guess, compartment syndrome and looking at circulation, that supracondylar fracture, I mean, it's in itself, it's a very common pediatric elbow fracture. So as soon as you see, a patient of like pediatric age and then falling awkwardly on their arm and fracture, you should be thinking this straight away. And then, yeah, some of the nerves that it affects are the median and the radial nerve, and you can kind of test them using the OK sign and getting them to put their thumbs up as well. And yeah, important to also note the 5 Ps, which were spoken about a bit before, so I won't really go into it. But yeah, so some of the tingling in his hand and the swelling would also kind of point to that compartment syndrome, which is, yeah, what's the word? A consequence of a supracondylar fracture. Cool. No, thanks everyone. Thanks Emil for putting the day together. He's done an amazing job, so I can give him a round of applause. He's had to deal with my bullshit, so. And good luck for your exams. Remember, Ps get degrees. Difference between a 90 and 50 isn't very much, so just put it out there.
Thanks, Sam. Now I'll pass it off to Div for genitourinary. Nah, it's yeah, I'm doing ID. It's not oh, grab some pizza. There's fun left. GeoIDs from the year 5s, they had like their life in the real world event today. So like they had a bunch of leftovers. I'd hate to see it, but yeah. Take a bag if you want, honestly.
Okay, this is the renal lecture. I love renal because it's to the point. I don't see that many trick questions, I think. I think you know the features and you're calm. We're gonna get started. Spoke too soon. Okay. Um, First of all, big credit to last year's lectures and some other past questions I found for these. And I won't talk your heads off with the explanations too much, but there's just a couple underlying principles I think that will help you answer most or lots of exam questions, especially if you're not sure. One, the idea of symptoms. Are they symptomatic? Two, are there complications, severe ones, when guiding you whether to do something or not? Um, the other consideration is, I guess, how old the patient is, or if they're actually going to benefit from, especially a surgical procedure. So, as you may know, the diagnosis is here is likely something like BPH. The idea as to whether or not you treat that then is revolving around, like we said, symptoms. In, I guess, enlargement of prostate is almost like normal aging. So for lots of people, they do kind of get on with it. But in this case, especially with the renal impairment, the answer should be that we do something about it, and the choice of procedure is just TURP. And we'll keep it moving. All right, when it gets to like 60, I'm gonna skip. Okay, cool. Sweet. So like I said, renal, not really trick questions. You know the features, you know the diagnosis, you kind of can do it. And as many people did. I guess what I'll say here is that like CTKUB, this is first of all, this is kidney stones. Hopefully the features were clear for that. The two options that we're really thinking about are a CT or of the renal tract or ultrasound. Most of the time, as is in this case, they won't even get you to choose between that. I think a lot of the time in real life, you might not even do imaging if it's quite obvious or if it's recurrent. There is a point to do with the type of stone, and if it shows up in imaging, you might have seen about before, which I tried to summarize. Basically, X-rays and CTs are the same kind of imaging. So the things that show up on them are things with calcium in it, like calcium oxalate. But it's not helpful for if it's like uric acid, so gout related, in which the point is that the CT can see everything. So that's kind of the idea. Okay, sweet. I think we're doing overall quite well here, and I'm really trying to be honest here. Like, I would expect questions like this, to be honest. But yeah, so the big idea here is that there is acute pain over 5 hours. That rules out a couple of the options already. And probably the main thing is that it's tender on palpation and the idea of the horizontal lie. Here's some other features of testicular torsion. And just think about what other features you'd expect in the other ones. I won't talk too much because we have other similar questions, but we'll keep going. Okay, sweet. So you might have had a talk about hernias earlier today. It's relevant to renal because it's associated, I guess, with like scrotum and testicles. The features here, I'll highlight the features here that kind of point towards it being a hernia first, and then we'll talk about the other ones. First of all, a couple things that tell you that it's not the others. It's not transilluminable, so it's not hydrocele. That's the first one. And then you can't get above the swelling, which is kind of telling you that it's not, I guess, a lump in the actual area. It's coming from somewhere else. So kind of get above pretty much hernia. The other trick, I think, is that like there's other swellings like lipoma that you also can't get above, but that wasn't an option here. Dull ache that's worse at the end of the day. The idea here is that hernias are worse due to increased abdominal pressure, so that's pointing towards it. But I think for the other ones, you can kind of you guys know a lot of key features of the other ones that tell you that it's probably not them. So for example, varicocele, of course, I think everyone has probably heard of bag of worms. So we're probably looking for that. That would have been the other one that you might have thought, which is also not transilluminable. And for infection, I think just think systemic symptoms, fever, dysuria, discharge. So it's probably not A. And seminoma is a common one, but I guess the other features, hopefully the large swelling, the other features just pointed more towards hernias. And here's just again some other things. So for spermatocele, painless distinct mass. And yeah, let's keep going. These are slides from the renal lecture as well. Oops. All right. Okay, cool. So like I said, features and knowing them in groups, in clusters, if you will, is super helpful for renal. This is an example of that. You think both symptoms and you think complications when you're trying to explain some of these things too. And hopefully just by looking at the options, you already kind of know what you're looking at. we saw a kidney stone question earlier, and while this shares right-sided sort of pain, and to an extent hematuria, there's some other things that weren't mentioned before, including hepatomegaly, and ideally we'd have an explanation for that, and as well as the specific vitals that we mentioned too. So let's keep going. So for polycystic kidney disease, a couple things point towards that. Bloatable kidneys, I think, is something that is a big flag for that. The systolic murmur, does anyone have an idea as to why they have that? Yeah, cool. And we'll talk about that in a second. But yeah, so we have associations with like valvular issues. That's good. And if we're thinking about the other ones, where if it's pyelonephritis, we're probably thinking they'll be febrile. Renal cell carcinoma, I think for the cancers, we're thinking painless hematuria usually. And IgA nephropathy, I think we'll get into more past stuff, but I think you guys might already have in mind ideal presentation for that, but I won't say too much. But yeah, so just more about polycystic kidney disease. We have dominant and recessive versions. The things that were flagged in this question were the hematuria, the pain, or the attacks of pain, I suppose. And the idea is that you can also get like hepatomegaly and where is it? If we look over here, for complications, big ones include berry aneurysms and, like we said, mitral valve prolapse and other valvular issues, not just MVP. Cool. I'm going to skip at 10 seconds. I'm so sorry to keep it moving. We'll summarize path stuff in a couple questions, I think. But the things that make, first of all, the diagnosis here, minimal change disease. Word on path for your like learning. When I say path exam 2, that includes things like blood tests and x-rays, things like that. When we're talking about histopath, I feel like a lot of that gets then shifted towards the like content exam, like exam 1, which I think for you guys kind of displaces a lot of the other renal content, which I guess is in some ways unfortunate because you've already been tested on it. But if you know it well, I think it will be helpful. So minimal change disease is really common, responds well to therapy. The key things we're looking for is that it's about effacement of foot processes on podocytes, causing protein leakage. It's also associated with, I guess, lipid issues like cholesterol as well. Next one. And again, I can't talk about the other ones just yet, but skipping at 10. All right. Okay, so how can we explain this? They have hemoptysis and hematuria, and a hypertensive, and there's lung involvement. So ideally, we'd have a diagnosis that explains all of that first, and then we can probably get to the answer a bit easier. So when we're looking at this, we're looking at basement membrane disease. To kind of there's other similar ideas of lung involvement with another group of I guess renal pathology diseases, which we can talk about in a second. But for now, let's focus on this. The idea here is that you have the syndrome, Goodpasture syndrome, which you may have heard of, is a pulmonary renal syndrome that involves both lung involvement, so pulmonary hemorrhage, as well as anti-GBM glomerulonephritis. So they're kind of separate. But when we're just looking at the kidneys, that's why when we call it anti-GBM disease, or glomerulonephritis. The idea is that it's a hypersensitivity reaction against the basement membrane, which is again also found. There's a basement membrane in the lungs, the alveolar basement membrane, and the idea is that you get nephritic syndrome as well as pulmonary hemorrhage. So that's where the kind of nodules come in. The other thing and hypertension just because it's nephritic syndrome. So yeah, linear staining deposits of IgG along the basement membrane because the basement membrane is straight. Cool. Let's again, like I said, we'll wrap up path in a second, but next. Okay, so we'll talk about that. Okay, cool. So that was IgA nephropathy. Nephropathy. Things to flag that. So first of all, blood, hematuria. So we're thinking nephritic syndrome. It's an acute presentation and it's in a young kid. And the other thing is that they happen to have signs of an upper respiratory tract infection at the same time. So the idea is that that's like the idea here is that that's IgA compared to post-infectious which would be a while after, like a strep infection. It also has happened before and resolved spontaneously. We had a question before, and there are some other path questions, but we might as well talk about it now, actually, about, I guess, granular, I can't even say it, GPA, and basically how to distinguish them. And I made some points about this in the lecture, and I'll try and stick to that and not like mislead you. But the idea here is that there's some involvement of some other areas of the body which are more specific to those kinds of diseases. Can anyone think of one? When we're thinking about GPA, eGPA, all that. Yeah, exactly. It's all about ENT. So like when it starts to talk more specifically about ENT issues, we're thinking more of them. And to be specific, so let's start with GPA. The idea is that that's exactly what was said. So saddle nose deformity, nasal bleeding, epistaxis, nasal discharge, chronic sinusitis, those kind of issues, plus lungs, plus renal. And then also just systemic symptoms of fever, weight loss, and things. I think those are probably the other ones that will help you know it's more of like a ANCA vasculitis in general. For eGPA, so eosinophilic granulomatosis with polyangiitis, we're more so thinking of allergic rhinitis and allergic issues, again, plus kidneys. You can get lung disease, but the other thing is like you can get like a rash. So it's a bit harder, but when you think eosinophils and allergies, that makes sense. And then for MPA, microscopic polyangiitis, it's a bit harder, but you get the rash. You also get GI involvement like abdominal pain and bleeding. and usually you don't get ENT involvement. So I ran through that pretty quickly. It's all in the lecture. I guess I wouldn't worry about it too much, apart from just so that you can know and be confident that questions like this are GBM disease. Hopefully that answers your question. Yep. And like we said, IgA nephropathy, here we go. Fever, so infectious symptoms plus hematuria at the same time. Okay. You may or may not have seen a past exam question on this. I don't know where this is in your matrix. I'm so sorry. I would say like under hypertension, that's where it should fall under. But the issue is that I don't think that's explicitly on your matrix. I could be wrong. It's relevant to renal because I guess they care a lot about hypertension in kidney land as well. The main thing is that you don't have features of the other ones. Like we've talked about polycystic kidneys. Cushing disease, I think you guys have talked about in endo or will talk about, but I mean, they've not clearly been on steroids. I think that the negatives is important. Urinary tract infection, they should make it more obvious, I think. The only thing that they've given us is just that they've added in an ACE inhibitor, with the idea being that that would set off a kidney issue in someone that had bilateral renal artery stenosis, which is otherwise asymptomatic. So kidney impairment following ACE inhibitor, renal artery stenosis. And last question, and then we'll just, again, like I said, explain the other options for path. And then we're done. And this might just be your only renal study for the exam. And honestly, I wouldn't, you might just be fine. All right, sweet. So nodular sclerosis or glomerular sclerosis is associated with or caused by uncontrolled diabetes. Is kind of the main thing. Again, so we talked about the other one. We'll talk about the other ones. IgA deposits, I think that's very clearly IgA nephropathy. Thickening of the basement membrane with spikes or silver stain. We're thinking membranous nephropathy. And the first one is more just a general kind of, it's quite general, but you could associate with post-strep. To summarize exactly what I'd want you to try and get out of renal, it's that the features are important. The management of most conditions, not so much. Maybe like UTIs. The chronic stuff, I think they don't really get you to worry about as much, and I think that's pretty fair. But the acute stuff, for sure. And then maybe just understand general renal imaging. What I explained before with kidney stones, I think is quite helpful. And like I said, path. Like if you know these path, I think you'll be very good for the exam. Please let me know if you have any other questions though.
Thanks, Steve. So now we'll just switch up the order a bit and we'll do Derm next because Derm will be on Zoom. And then I'll finish off with ID. So Just give us a second and we'll set it up. Oh yeah, feel free to take some food. Asmitha, are you able to say something?
Yes, I am here.
Oh, cool. Basically what you can do is you can request to have control of my cursor.
Okay. I'm going to try and figure out how to do that.
So you can control it.
Oh, okay, cool. Cool, thank you.
And I think that should allow you to, yeah, do everything.
Cool, thank you.
No worries. Oh, yeah, and feel free to start whenever.
Okay, sure. Hi everyone, I'm Asmitha. I'm not sure if you guys can see me or not. Hopefully you can. And I'll be doing the derm part of your revision session. Well done on making it so fun. Sorry I couldn't be there in person. If that's all, the people, we can probably start now. So I'm going to click start in 3, 2, 1. Okay.
And just click next on the slide as well.
Oh, sure. Right, it's a bit of a wordy question, I know, but all right. So with this question, so firstly, a 67-year-old male presents to the emergency department with a 5-day history of growing redness. Actually, I'll see if I can go to the next slide. Yeah, okay. So he's got growing redness, pain, and swelling in his left lower leg. This could be a lot of things. It could be, like a DVT. It could be cellulitis. It could be erysipelas. It could be a lot of things. In this case, he has a past medical history of type 2 diabetes, so that's kind of pointing you towards the cellulitis type of picture. He also has a fever, so a temperature of 39, so also infection. He's tachycardic and he's hypotensive as well. And he has a known non-anaphylactic penicillin allergy. So this patient, so the diagnosis for this patient is cellulitis with septic shock. So it's septic shock because he's tachycardic and hypotensive.
And basically, what you need to know for cellulitis is basically the step-up sort of regimen of antibiotics that you would use. So if you have cellulitis with septic shock, then you would use the same empirical treatment that you would use for necrotizing fasciitis. So in this case, it's IV meropenem, vancomycin, and clindamycin. If you just have very severe cellulitis with systemic features but no septic shock, then you can just give vancomycin or Bactrim. So I've written the step-up treatment here. So for the usual presentation of cellulitis, you would usually give flucloxacillin, oral for mild, and IV if you want to hospitalize them and monitor their progress in hospital. And then if you have a non-anaphylactic allergic reaction to penicillin, you give cefalexin. And then for severe cellulitis, like I mentioned, it's vancomycin or Bactrim, but vancomycin is preferred. Yeah, if anyone has any questions, feel free to ask as well. I can't really see you guys, but feel free to just shout it out. I'll move on to the next question. Cool. Well done. To half of you guys. Basically, in terms of if they give you a lesion that's on the lips, then what you need to know is that BCC usually occurs on the upper lip and SCC usually occurs on the lower lip. You don't need to worry too much about the actual appearance of it. But in this case, the appearance as well is more characteristic of an SCC. But basically, the main thing for lesions on the lip that you need to know is that an upper lip is going to be a BCC and a lower lip is going to be an SCC. In real life, you could get a BCC on the lower lip, but in Monash land, that's generally what they would go towards. So in this case, it is an SCC. Yeah, don't worry too much about the appearance though, because it's a bit hard to tell when the lesion is located on sort of the lips or just any other location that's not the normal skin. It's difficult to tell the distinguishing features. But yeah, this one is an SCC. And the way I sort of remember it is B comes before S in the alphabet, so B is on the top, and then S is on the bottom. Okay, I'll move on to the next question. Cool. Good job, everyone. It is a venous ulcer. So the main things to note in this case are the location and the appearance. So a venous ulcer is usually located in the gaiter region of the lower limb. So that's sort of the region that you can see over here where the ulcer is. It's sort of near the ankles. And that's very characteristic of a venous ulcer, the appearance as well. So I think for ulcers, the main thing that you have to know is learning to differentiate between the appearance of an arterial ulcer, venous ulcer, and a neuropathic ulcer. So with the arterial ulcers, you normally get that sort of punched out appearance, and it's generally more red. whereas venous ulcers tend to look a bit more shallow and a bit more of an irregular shape and around the gaiter region, whereas arterial ulcers are found more near the bony prominences. And neuropathic ulcers are sort of where you would injure your foot. That's where you find neuropathic ulcers. So like under the foot, bony prominences, that sort of thing. So yeah, well done, everyone. Okay, so in this case, the answer is the Auspitz sign. So basically, the Auspitz sign is most likely to be found in patients with psoriasis. Denny-Morgan creases and hyperlinearity are signs that you would see in eczema or atopic dermatitis. So what the Auspitz sign actually is it's the appearance of pinpoint bleeding after removing scales from the skin surface. And in psoriasis, you basically get dilated blood vessels within the papillary dermis. So that's why you get that pinpoint bleeding when you remove the scales from the skin surface. And keratosis pilaris is a different condition where basically the hair follicles sort of get plugged and blocked with keratin, and that forms these small bumps on the skin. And that's not really a sign that you would necessarily find in association to psoriasis. So hopefully that makes sense. And as always, if you have any questions, feel free to ask. Otherwise, I will just move on to the next question. Okay, good job. So most of you guys got this one. So melanoma is not a clinical diagnosis. You need a biopsy to confirm melanoma. The other three are clinical diagnoses. Like, yes, for the other three, there might be certain investigations you can do to help, like determine the severity or the triggers or to confirm. But at the end of the day, the other three are still a clinical diagnosis. You don't really need any investigations to actually confirm the diagnosis. Melanoma is the one where you would definitely need a biopsy. Yes, there are clinical features that would make you suspicious of a melanoma, but you can't actually say it is a cancer until you biopsy it. Okay, I think most of you guys have answered that, so in the interest of time, we might move on. I think if I click, yeah, okay. So with this one, so I'll go on to the explanation. So basically, what acantholysis is the loss of intercellular connections due to an immune reaction that targets the junctions between the cells. And you would see this in conditions like bullous pemphigoid. So this is not really something that's associated with other sort of conditions. It's mainly associated with bullous pemphigoid and pemphigus vulgaris. This is like more of a path-related question. You could answer this question through just ruling out the other options, because with acantholysis, you wouldn't really see that in anything except for the bullous disorders. And then these other three things are things that you would find on biopsy of a HSV infection. Yeah, so honestly, like I wouldn't really bother learning, these specific things are what you would find if you biopsy a HSV infected lesion. What I would know is what acantholysis is, and you would easily be able to pick that as the answer. If you can identify that, that would only be found in sort of bullous disorders, and not necessarily other skin disorders, if that makes sense. Yeah. Cool, I'll move on to the next question. Okay, so there was a split for this. I kind of knew that a lot of you guys would pick yellow, and I'll go through why that one's not the answer. So, firstly, the reason why B is incorrect is because the rash that's associated with acute rheumatic fever is actually called erythema marginatum, not erythema multiforme. That's something different. I'm pretty sure rheumatic heart disease is like R1 or R2. I would definitely learn the clinical signs of and symptoms of rheumatic fever. And you can get a rash called erythema marginatum. And yeah, erythema multiforme is like a different skin condition. With option C, actually, pyoderma gangrenosum is associated with both Crohn's disease and ulcerative colitis, but it's just more commonly seen in ulcerative colitis compared to Crohn's disease. So technically, that's still a correct option. It's the same thing with erythema nodosum. That's associated with both of the inflammatory bowel disease as well, but it's just more commonly seen in Crohn's disease. So we associate that with Crohn's disease and pyoderma gangrenosum with ulcerative colitis. But in reality, you can actually see both of those rashes with both of the inflammatory bowel diseases. So that's technically not an incorrect answer. So yeah, in this case, the answer is B. Okay, I'll move on to the next question. Okay, in the interest of time, I'm just going to end this since most of you guys have answered. Yeah, so the answer in this case is 50%. So around 50% of melanomas arise in the previous nevus, and this just is a fancy word for mole. Usually it's just a benign nevus. Sometimes it can be large congenital moles or dysplastic ones. But yeah, 50% do arise from a previous mole, and 40% are from just the normal melanocytes in the skin, so just on normal skin. And then the the last 10% is are melanomas that would occur in genetic syndromes and tumors of internal organs, because not all melanomas arise on the skin. So yeah, the answer here is 50%. Okay. Yeah, good job. Most of you guys got that one. So I wouldn't really bother learning all these other ones. Just know that S100 is associated with melanoma. Because sometimes they have put that in questions. They might say, this tumor is associated with S100. They'll usually give you a bunch of other clues to point towards a melanoma as well. But they have included it in a few questions. Yeah, the others I wouldn't really bother learning, but do know that S100 is associated with melanoma, and it is a diagnostic marker that they use to identify melanoma. Oh, whoops. Okay, moving on to the next question. Last question. Okay, cool. Good job. Most of you guys got this one. So this is just one of those things that you have to know. Option A, so that's a tender, well-circumscribed raised nodular lesion with central ulceration / necrosis, is the description of an SCC. Option B, which is an enlarged flat pigmented patch on the face or upper body of an elderly person, is lentigo maligna, but I also added with telangiectasia to make it more confusing. But normally you don't get that. That's just not associated with a lentigo cancer. And option D is describing an acral lentiginous melanoma. So that's an irregular patch with dark colored nodules on the soles of the feet. It can also be found on the palms of the hands as well. So a BCC generally presents as a raised nodule with central ulceration / crusting and telangiectasia. So telangiectasia is one of the buzzwords to know for BCC. Sometimes they might also describe it as a pearly white border, or like a shiny border. That's also a buzzword for a BCC. So I would know those two buzzwords. They do like to test you a lot on the skin cancers. They are quite high yield. So that's SCCs, BCCs, and melanomas. Those are some of the main derm questions I would say that were on the exam. The skin cancers and a few of the other conditions as well, like the inflammatory conditions, eczema and psoriasis as well. They're pretty high yield. So I think that is it from me. Oh, sorry, you guys might want to see your scores. Yeah, so thanks everyone. If you have any questions, feel free to ask as well. I'm happy to answer them. Cool. Congratulations to Michael Jackson for coming first.
Thank you. All right, now we'll finish off strong, and I'll take us through infectious diseases. All right, I'll get started, and people can keep joining as the thing's going. Good on you all for staying to the end, and we'll try and get this done well. I tried to include questions that were mostly high yield and things that are relevant, as opposed to things that were too niche. And also just a shout out to Sophie Khan for doing the infectious diseases lecture. Alrighty, gonna skip in 5 seconds. Okay, well done. Everyone's done very well in this question. So we've got a patient with a known history of HIV who's got a basically pneumonia picture. And so with the CD4 count of less than 200, that's when you can start to see a lot of those AIDS defining conditions, such as PJP, and also other things like CMV pneumonia, you'd see even at lower CD4 cell counts. So that's like even below 50 is when you might start to see CMV pneumonia. Gonna skip at 20 seconds. All right, yeah, well done. Most people have gotten typhoid. Just to go through these options. So typhoid is what you would see most likely in a returning traveler. You've got typhoid, high-grade fever, and then especially the constipation followed by diarrhea is something that you see in typhoid. There's also the relative bradycardia and the maculopapular rash, which is quite classic. So in terms of cholera, that's when you see the rice water stools. And does anyone know where you'd see Shigella? Yeah, I think so. I think I heard someone say it, but men who have sex with men that's kind of the buzzword for Shigella. Oh. Gonna skip in 4 seconds. All right, well done. Yeah, so I didn't try to make these questions too hard. I think we had a question very similar to this on our exam, but the thing that's very classic of EBV infection is a young person, and also the rash after being prescribed antibiotics, and particularly amoxicillin is very, very like a buzzwordy for EBV. All right, gonna skip soon. All right. Yeah, so I think it's good to see that everyone's kind of tossing up between malaria and dengue. So in terms of differentiating between the two, it can be quite difficult at times because in both malaria and dengue, you can see signs of hemorrhage, but even though that's not in this stem. So I think the main thing in this stem that kind of differentiates between the two is the 4-day history, because malaria usually has an incubation period of 7+ days usually, whereas dengue has a shorter incubation period, and that's because dengue is a virus. So the other thing that's kind of pointing to that here is the severe muscle pain, because dengue is sometimes often referred to as break bone fever. Okay, gonna skip soon. All right, well done. Yes, it is influenza. Yeah, the stem is very classic for that. With the other options, you would see, I think, quite different things. EBV, infectious mono, as we said before, probably a younger patient. Strep pharyngitis, you're more likely to see some changes in the throat, and then pneumonia will be quite different. All right, I'm gonna skip soon. All right, well done. Yes, so this is what's the diagnosis that we're thinking of here? Yes, rheumatic fever. And so for rheumatic fever, the first line therapy is benzathine benzoyl penicillin. Does anyone know how that is administered? Yes, I am. Good. Okay, I'm gonna skip soon. All right, well done. So I think most people were tossing up between red and green, and with this, what score do we use to classify the severity of pneumonia? Korb score. Yes, exactly. So what is this person's Korb score? Yes, 2. So they're not confused. Their oxygen is below 90. The rest rate is above 30, and the blood pressure isn't specified, and they're below 65 years of age. So the Korb score is 2, which would mean that it's probably a moderate community-acquired pneumonia, which is why the answer is D. All right, I'm going to skip in 5 seconds. All right, well done. Yeah, these questions aren't meant to trick you, and I think this is honestly the quite a large majority of the questions in the exam. This is usually the standard that they ask of you. I'm going to skip. All right. Yes. Well done to most people who got an meningitis. So the non-blanching petechial rash on the trunk is what kind of pushes you towards thinking of Neisseria as opposed to strep pneumo as the cause of meningitis in this case. Last question. We'll skip in 5 seconds. Alrighty, well done. So again, I think everyone's picked up here on the key parts of the stem, which is suggesting that this is a gonococcal arthritis as opposed to Staph aureus or any other causes. So yeah, particularly in a young patient who is sexually active and engaging in sexual activity with multiple partners, always consider gonococcal infection as a cause of septic arthritis. And that is it. I just want to say at the end of today, thank you all for staying for so long. And I hope that this format, considering we were trying it new this year, worked well. So please pass on any feedback you have to me. I'm more than happy to hear what people have to say. And thanks a lot and best of luck for your exams. I'm sure you're going to smash it.